or high-income countries, because in low
Hi, everyone. Dear friends, and friends, everybody, thank you for coming all the way to Lisbon to be here at our 9th anniversary as a foundation and our 7th RSVVW meeting. My name is Louis Bond. I'm the chairman of Resvinet, and Leila Krachten, my partner in crime for the foundation that you all know, will introduce herself in a second during the second part of the welcome words. You have no idea what it means to be here with so many people we have been working with over the past so many years to fight a disease that was causing so much problems to our children and adults. And now we're going to hit back, right? We got the virus where it's where we can hit it best. I just want to share a few words with you about our foundation. Just put on my glasses, otherwise I can't read myself. Our vision, yeah, you need glasses for a vision. To connect global expertise and leadership in order to decrease the global burden of RSV infection. With our mission to support performance of high-quality research, to improve knowledge of RSV epidemiology, to develop safe and effective therapeutic and preventive interventions, with the goals to advocate and create awareness of RSV infection, to act as a focal point for effective partnerships with stakeholders, and to combine knowledge and capacity required to enhance development of novel RSV therapeutics. I think it is amazing that the foundation started almost 10 years, so 9 years ago, with exactly these words, and we didn't need to change it because this is who we are and this is why we're here. 33 million cases in children, 3.6 million hospitalizations, more than 100,000 deaths, 360,000 hospitalizations in older adults, although I think everybody is aware that the numbers are still uncertain, and a substantial number of deaths in the older adult space. A lot of reasons to be here and to fight RSV. So, who are we? We find RSV awareness and education very important. We organize webinars for professionals, but also webinars for parents and the general public. We just translate the professional webinars for those who are not using the same terminology that we use. We have social media awareness campaigns and interviews with parents. We support studies and clinical trials. We provide peer-to-peer RSV education for study teams. We provide protocol development advice, and we represent the patient perspective. At least we let the patient provide their own perspective in research and development of RSV therapeutics. We have been setting up and participating in specific studies, such as the PROMISE study. We have been funded by IMI, a public-private partnership, EU-funded study led by Resvinet and myself. We have been doing the INFORM study that looks at RSV global molecular epidemiology. We have studied RSV mortality, really understanding the value of RSV prevention, and we have done various RSV studies in children and older adults, both observational and intervention. So one of our next ambitions is to build a dashboard. We will create the first global RSV surveillance dashboard that is available to everybody, that is wider than what is currently available. We hope to launch it next month with a start in 20 countries and expand it in the years thereafter, which was generously provided as an unrestricted grant to our foundation by AstraZeneca. We have been very active in the field of publishing. You can see that the PubMed study, PubMed search shows an increasing number of papers, including a number of papers that are really well known in the RSV field, such as landscape papers by Nathalie Mazur and an European burden study by Joanne Wildenbeest, and many more, as you can see. Our webinars have been planned every 2 months. Sometimes there's a little bit of a gap, for example, because we have a meeting now, we allow for some time interval. They have been well attended and well evaluated over the time, and we have had 11 webinars so far, and we will continue to do that because we think this is an important way for us to contribute to knowledge and awareness. Our next webinar, the date is to be announced, will be on current landscape of RSV immunizations by Barney or something in that line. He has agreed to provide that webinar in 2 months or so. We will keep you updated about the exact date. So we have a very active patient network. You will hear more about that in session 1, as you have seen in the program. We are there for parents of young children and the children themselves, obviously, but also pregnant women and adults over 60 years of age, the target populations for our interventions for obvious reasons. So the patient network focuses on awareness, education, and prevention, and really has a message that speaks to parents and the public in a much better way than we as professionals and as academics can do. The Patient Advisory Board is international. You can see where we have been getting support from parents of children with RSV, and we have now started to expand that to adults as well, because we find it important that we represent all RSV patients around the world, and we will also expand to low and middle income countries. So this is a good moment for me to give the floor to Leila, who will tell us why Resvinet number 7 is such a success. Leila.
Thank So also from me, on behalf of Resvinet Foundation, welcome everybody. Thank you for coming all the way to Lisbon. Indeed, we have a very large number of participants this time. So we have 550 participants coming from 48 countries. So it's really wonderful to have so many countries represented here, and 6 continents, of course. And we have been able to provide 55 travel grants to young researchers and to researchers from low-middle income countries. And we are happy to have you all here. So we have researchers, we have physicians, we have pharmaceutical companies, but also WHO, Gates Foundation, NIH, and PATH. So thank you, everybody, for being here. Of course, it wouldn't have been possible without the support of our sponsors. The Gates Foundation and PATH, with your support, we have been able to provide the travel grants, so thank you very much, and also the other sponsors for making this possible. So nothing, I don't have to say anything here, so a lot of speakers and session chairs, thank you very much all for agreeing to present your data here and to contribute to our sessions. So you will be seeing them in the coming days. Our organizing committee, I'm sure a lot of you have had emails from Roxy and Nina in the past months. They have been doing actually all the organizational work. And also our conference chairs who have been involved from very start on to develop the scientific program, and advising on different aspects of the conference. So Padmini, Paolo, and Dan, thanks very much for your support. And of course, also really big thing. So every time from Resvinet, we try to have, during the conference, we try to have an inspirational speaker. So that's someone who has nothing to do with RSV or vaccines or whatever, but somebody who has achieved a really big, goal. And so this time we will have a sailor who has been 7 times world champion and also 3 times in Volvo Ocean Race participated. He will be here this evening, so during the reception, which is downstairs this evening, then he will be at 8 o'clock. He will be presenting and hopefully inspire you to also reach your goals and how he has done it. So I would say all come and watch. I think I'm there. Yeah, so enjoy. These days, I think okay. We are having to have a great program, and together with you, it will be perfect. Yeah, okay. So Louis has some points to add.
Two housekeeping points that Dr. Mohsen Nagavi, if you can, perfect.
Already done.
Our speaker of the first session, we just want to be sure that everything is taken care of. And I would like to invite all the participants working in low and middle income countries in the developing world to pass by the poster at the right side of the stairs over there when you just step out. We want to work with you. We will explain it there. But at the right side of the stairs, please come there during the break. And then I'll...
Now we give the floor to the session chairs.
Hi, good afternoon, everyone. And thank you, Luis and Leila, for opening the conference, and of course to Resvinet for organizing all of this. My name is Padmini Shrikantaya. I'm a deputy director in the pneumonia team at the Bill and Melinda Gates Foundation, where I lead the RSV strategy. And it's incredibly exciting moment for RSV right now, as Louis mentioned earlier. Just an incredible amount of progress and data, both in understanding burden of RSV, as well as what we can do to actually combat this problem, both in young infants and in older adults all across the world, where I'm sure all of us hope to make a great impact. So thanks so much for joining us, and I'll turn over to my co-chairs.
Hi, I'm Dan Weinberger. I'm an associate professor of epidemiology at Yale School of Public Health, it's great to see everyone here. It was been a pleasure sort of reviewing everybody's abstracts and seeing all the great work that's going to be presented this week, and I think it's going to be a fantastic program, and I'm looking forward to it. Thank you.
Hello, it's Paolo Manzoni. I'm a neonatologist based in Torino University, Italy. I'm also very proud founding member of Resvinet, and in this role I add my welcome to Luis and Leila's welcome on behalf of the entire board and entire foundation. And I acknowledge and thank the work and the dedication of Padmini and Dan together with me, and together with all the scientific advisory committee that you are seeing here later. Okay. Scientific advisory committee, having worked hard and efficiently for developing the program, for reviewing the abstracts, for adjusting topics and areas. One of the very nice things about the Resvinet Conference, and more generally about Resvinet, is that since we deal with RSV, we are by definition a multidisciplinary group of physicians and dedicated scientists and clinicians. So each one of us is representing some area. All of these areas are equally necessary to understand better the role of RSV and what we need to do for our patient. These were the main drivers that inspired us in developing the program. We obviously, in line with the Resvinet tradition, need to show the latest development in RSV research, but in line with our mission, we also want to focus very heavily on what happens and which are the needs and the unmet and the gaps in low and middle income countries. And once more, we include a diverse panel of speakers, not only multidisciplinary, but also multi-geographic. This is a brief overview of the program. You all have the program both printed and in the online. The first session will be chaired by Beate Kampan and Cheryl Cohen, and will be opening the stage and dealing with the burden of RSV disease and mortality. Then we'll shift to the Young Researchers Tournament that's open to all. Ruth Caron will chair this very intriguing session. Session 2 is a focus on the global epidemiology of RSV, and Dan and Joyce Nero will chair this session. The third session will focus on clinical intervention and their global use, and Sanjuti Saha and Keith Klugman will chair this session. The fourth will be about vaccine delivery and uptake, with Patrick Muniwicki and Marta Nunes chairing this session. Ron Dagan and Eugenio Baraldi will chair the session 5, focusing on the secondary effects of RSV interventions. The session 6 will be chaired by myself and Pablo Sanchez, and will be again about clinical interventions and global use in the area of RSV. And the session chaired by Mark Jitt, the number 7, will be inspiring reflections and consideration about health economics with the monoclonal antibodies and the maternal vaccination scenario. But the first session, if we want to define session, is a great one, is a keynote opening lecture, and it will be held by Professor Peter Openshaw from the Imperial College in London. I'm inviting Peter to join the stage and to take the microphone. It will be our pleasure to give the floor to him. This will be a 40 minutes lecture, and please, Peter, join us.
Well, thank you so much. It's a genuine honor and a privilege, and I'm so grateful to the organizers for asking me to give this sort of 40-year backwards view of how we arrived at where we are now, which I think is what the intention was in asking me to give this talk. So it's been a long journey, and here we are on the verge of having, so many effective vaccines, effective preventive treatments, but also in a genuine understanding of the disease. And I guess that's really what's motivated me over the past 40 years in trying to work on this pathogen. And I thought I'd go back to a couple of my inspirational mentors from the early days. This is Professor Margaret Turner Warwick, and I worked for her at the Brompton Hospital in 1981 to 82, and she at the time was probably the world's greatest expert in lung inflammation and in lung immunology in the clinical arena. There weren't many people studying lung immunology and lung inflammation at the time, and we were referred patients from all over, not only the UK, but also from Europe, sometimes even from North America, who would come to her for an opinion about their inflammatory lung disease. So I was training as an adult respiratory physician, and she at the time was the only professor at the National Heart and Lung Institute, and was an extraordinary woman, absolutely remarkable. And I guess that in working for her, I became passionately interested in what caused lung inflammation. We really didn't know what was triggering this inflammation. I remember a long presentation to her one afternoon, and after we'd gone over all the details, she said, well, this is another case of immunological mischief. And I thought what I needed to do was to go away and find out more about the immune system. I didn't understand much about it. Most of us didn't understand much about it at the time. If we wanted to understand this immunological mischief, I needed to start working on a disease that caused inflammation, the cause of which we knew. And I thought, what better than working on respiratory syncytial virus? So this was really intended as a route to get me back to inflammatory lung disease and to understand lung inflammation in those patients. And, it's not only that RSV causes this intense inflammatory response. You can initially see cells coming out from the arterioles, spreading around these respiratory bronchioles, and then migrating out into the lumen of the respiratory bronchiole and causing obstruction. But there was also this very intriguing observation that was emerging at the time that long-term lung health might be impacted by bronchiolitis, and that babies who had been admitted with bronchiolitis had a much higher frequency of asthma during subsequent life than the controls who were not admitted despite being infected with RSV. And the question about whether this inflammation that we see in bronchiolitis has long-term effects in terms of asthma and other chronic lung diseases was a very live one at the time. So that really motivated me to think, how can we start working on this virus? I think the third real bit of evidence that was so intriguing was the evidence coming from these studies attempting to develop vaccines for RSV using formalin inactivated RSV. This had been a very optimistic time back in the 1960s, where many different groups tried to develop vaccines for many diseases. Some were successful, some were not, and this is probably the most dramatic example of an unsuccessful attempt at developing a vaccine. There were 4 trials that were launched more or less at the same time, and this is an example of one study in which children were either given an RSV vaccine or a paraflu vaccine, both formalin inactivated, and then were compared in parallel. So a very nice balanced design of a study. In the control group, given the paraflu formalin inactivated vaccine, the hospitalization rate was 5%, so that's a fairly typical hospitalization rate. But in those given the formalin inactivated RSV, it was 78%. And 2 children died in these studies. So again, this made me think this is a fantastic model for understanding lung inflammation. At the time, it was really not easy to know how we were going to be able to study lung inflammation in humans. And, animal models were the thing. Some people worked on hamsters, others worked on rats. There was a big debate in the immunological community about whether rats or mice were going to be more useful as animal models. And I was sent to see this second mentor, Ita Askenas, a most remarkable woman whose family fled from Austria to Canada because of the Nazi persecution. And she was a very witty, very clever woman, a relentless critic. And I think we all had to understand that her criticism was meant kindly, because if you didn't understand that, it really drove you down. But she was a great mentor, and I was her last PhD student. So when her lab closed, I was able to, with her support, set up my own lab and to work on the mouse model. So this is one of the nice early papers on the mouse model. This was from NIH, where Greg Prince and Bob Chanak and others took a range of different mice from the animal house at NIH, infected them all with RSV, and you can see that there's a big range in terms of the response of these different inbred mice. So the mouse is not just one model, it's a genetic range of models, different inbred mice, different effects. The field more or less settled on using the Balb-C mouse because it was very convenient, and they were easy to breed and easy to look after. But I just wanted to put this up to emphasize the diversity. So this was one of the very first papers I ever published on RSV. And when I was working for Turner Warwick at the Brompton, we had a flow cytometer. It was very exciting. We had a flow cytometer. There was one laser, one channel. So we had to run the samples again and again and try and infer the populations. When I went to Mill Hill to work with Ita Askenas, we had a 2-color flow cytometer. So we were able to look at the cells and see what proportion of them were CD4 and CD8. They weren't called CD4 and CD8 in those days. But you can see that we were able to then do a time sequence of the responses, the inflammatory responses to infection in this relatively new mouse model. So, in our hands, the mouse model worked relatively well. There were a couple of key techniques that we developed, one of which was to weigh the mice. People didn't know how to monitor the severity at the time, but by weighing the mice day by day, we got quite a nice index of how sick they were. This didn't sit very well with my pediatric colleagues who were never seeing weight loss of 20% in babies infected with RSV, but it was a very good way of monitoring severity. The other thing, which I really brought from adult medicine, was doing bronchoalveolar lavage as a convenient way of doing a sort of liquid biopsy of the whole lung, and thereby selecting cells that were almost ready for flow cytometry in suspension. And that greatly sped the development of these models. So in terms of augmented inflammatory disease, which was what I really wanted to study, one of the first things we did was to try to inject into these mice CD8 T cells in the hope that these would clear the virus and restore the mouse to health, because T cells were relatively new in terms of study in those days. Very few people were able to study them, and we were convinced that they would be as good or better than antibody in terms of clearance. What we actually found was that the mice became acutely sick when we injected them with CD8 cells, if those CD8 cells were injected in large numbers at the beginning of disease. So the injection of T cells was actually augmenting the severity of disease, which was bad in terms of understanding protective immunity, but great in terms of understanding this inflammatory condition. The other thing that we spent quite a lot of time on was vaccinating mice with recombinant viruses that have been provided to us from wonderful collaborators, generous collaborators at NIH. They were making these recombinant viruses and sending them across the Atlantic, or I was going on a flight and putting them in my pocket and bringing them back. In those days, almost no regulation about moving viruses around. And we could then infect groups of mice with recombinant vaccinia expressing single proteins, the fusion protein, the M2, 22K protein, or the major surface glycoprotein G. And in the BALB/c mouse, if you primed them with these three different antigens encoded by vaccinia, and then infected them with RSV intranasally, so this is the first time they're actually meeting an intranasal challenge, we got three different inflammatory syndromes. So lung neutrophilia, which was moderately severe, lung neutrophilia, again with very strong CD8 T cell priming with this M2 protein, which was sometimes lethal, and then lung eosinophilia, which to me as an adult doctor looking after people with asthma, I thought was really interesting and might link the mouse back to the association that was being observed between neonatal infection and the later development of asthma. So this shows the sort of weight loss curves that we get with mice primed with these different antigens. So the most aggressive inflammation was induced by this M2 expressing vector, which caused very powerful CD8 T cell response in the absence of any neutralizing antibody. So the next thing, I guess in the sort of history of our work in the mouse looking at augmented disease was this study, which Fiona Cully did when she joined us for one of the very first big collaborative EU projects that was funded as we started to build that fantastic EU funding that we've so depended on over the past 15, 20 years. And I must say, as an aside, what a deep regret it is that our government has chosen to exclude us from those collaborative grants. So what Fiona found was that if mice were infected neonatally, they actually seemed to shrug off the infection with apparent ease. So no evidence of severe disease, no mortality, they continued to grow normally. But if you took a mouse primed in such a way and you re-exposed them to RSV in adulthood, then there was disease augmentation. So there seemed to be some sort of imprinting that went on in this neonatal period with very mild or inapparent disease resulting in a later exacerbated response to RSV challenge in adult life. But the so-called imprinting needed to happen within the first week of life. So it's a very specific time window when these mice can be sensitized by a first infection. The other great thing about the mouse model was that we could get some more beautiful recombinant viruses, which I think might be quite difficult to create these days. But these were viruses which were generated by Peter Collins and others over at NIH, where we had RSV that encoded interferon gamma genes or IL-4 genes, so that with the infection with these recombinant viruses expressing a cytokine or chemokine, we could look at the way in which co-delivery of that chemokine or cytokine modified the severity of disease. And if we look at this chart on the right-hand side, this is airway eosinophilia, and you can see what a remarkable eosinophilic response you get if you infect mice with recombinant RSV encoding IL-4. So these were exciting times. This was very novel, both in terms of the virology and also the immunology. This is another one showing what happens if you deliver these mediators by recombinant RSV into neonates and then challenge in later life. And this effect, this imprinting effect, which we described in the neonatal mice, actually persisted right up to adulthood. So very long-lasting effect depending on the cytokine environment, the context in which RSV was first encountered. So that's a lot of information gathered over many years and is really just a sort of superficial canter through some of the things that we studied. There's a lot of it is summarized in this annual review of immunology that we wrote, and I think this is rather a pretty depiction of the different ways in which RSV can cause inflammation. So during primary infection, macrophage-centered inflammation suppressed by regulatory T cells. The virus certainly induces pathology, but actually most of the pathology that we see is inflammatory. It's an inflammatory response to the virus. We can see varieties of inflammation that are predominantly neutrophilic, and that in particular is associated with very strong CD8 T cell responses, or eosinophilic if we prime with specific antigens or in the context of overexpression of Th2 cytokines. And then the memory responses, which can also be pathogenic and which can be quite long-lasting. So, we have quite a comprehensive picture coming out from all of these mouse studies, which I think formed the setting for what we subsequently were able to do. I think the other thing to emphasize is just what a lot we learned from the mouse model in terms of the sequential timing of these effects. So to understand the inflammation, you really have to think about the timing. And we could do that beautifully in the mouse model because we knew when the virus was being introduced, and we could take samples at specific times after infection and look at the different modalities of the immune system and see what mattered when. And I think the early importance of interferon, infection history, I haven't described those studies, but we did quite a lot of studies with altering the infection history of the animal, and that also has an effect. And of course, viral replication is at the center of all of these responses, but is necessary but not sufficient in terms of causing the disease. Indeed, when we try to relate the amount of virus with the amount of disease, there's often a disconnect, whereas there's a very direct connection between the amount of inflammation and the amount of disease. And in terms of resolution and convalescence, I think many of our studies did emphasize the importance of T cells, but these were not, as we had initially suspected, very important in the early stage of disease, unless they're perhaps resident memory T cells in the mucosa. But the T cells are important in mopping up those last traces of virus and in ultimate elimination. So I think we've learned a lot from the mouse. And I think it's been a huge contributor in terms of giving us the context for then going on to study the disease. You know, the studies absolutely emphasized the importance of looking at the mucosa. You know, many of the human studies which were going on were really just looking at the peripheral blood. And we knew from all the animal studies that the peripheral blood is often a rather pale reflection of what's going on in the primary site of infection. We know that the responses evolve over time in a very well-regulated sequence, and that the disease is predominantly an inflammatory one, and that we could enhance severity by priming the immune response in specific directions, and that although the virus is necessary, it's not sufficient in order to cause this very severe disease. Indeed, in immunosuppressed mice, they develop rather a chronic indolent disease, which doesn't really cause high mortality until quite late. So, from all that work in the mouse, we started to really worry about how much this could be translated into humans. And there was a lot of debate going on in the, I guess, 1990s and the early part of this millennium about, you know, how much we could then learn to translate. You know, is the mouse an accurate predictor? You know, I don't think that the mouse lied. I think actually the mouse told us a lot of truths, but those who didn't work on the mouse were very much prone to overinterpret what was being done in the mouse in terms of understanding human disease. So I think, you know, my take on it is that many of the basic principles of what we needed to know were learnt from these mouse models. Now, sorry, is that going? Yeah. So, so coming back to my interest in adult lung disease. Now, this is a graphic from the annual reviews of immunology that we wrote, emphasizing that although RSV is a disease that causes disease in babies, also this relationship to later development of recurrent wheeze and asthma diagnosis, it also causes an insidious respiratory illness in older adults. And I think, you know, our colleagues in Rochester have really emphasized the great importance of RSV as an adult pathogen as well. So, you know, we were really puzzling how we could contribute to understanding this disease in adult humans with all the experience that we'd had in the mouse models. Now, one of my early PhD students, Anne Cherry, had actually taken some virus that had been given to us when the Common Cold Unit was closed down by the Medical Research Council. And they had these stocks of virus that had been used for human challenge, and people were retiring. They didn't know what to do with it, so they phoned me and said, could you have any use for this human challenge virus? So we asked around the lab whether anyone would mind being infected, and we thawed out some of these vials, and we infected 2 cohorts of volunteers. And I remember one particular postdoc who got a really terrible cold. He was producing about 20 grams of nasal mucus per day, which Anne was measuring faithfully every day. She was weighing his paper hankies, desiccating them, getting the wet weight. So, you know, it was quite dramatic, but it was not a very systematic entree into human challenge, I would say. It wasn't being done under the sort of conditions that we would now do human challenge. But human challenge has got a great history. You know, it's actually, if we look at the history of human challenge here from, say, the 1940s, 1950s, coming up to, you know, more contemporary times, there's been a growth in the number of clinical trials involving human challenge, a lot of them with, say, malaria, but also with influenza. And, you know, RSV has got quite a history of having been the subject of human challenge studies. So, we thought perhaps we ought to do this more systematically. There are great advantages in doing controlled human infection studies. You know exactly when the virus is put in. You can take samples sequentially. You can look at the interval between virus administration and the onset of infection or disease. Clearly, there are hurdles to be overcome as well. The ethics are complex. You have to get the logistics right. You have to be sure that they can be done reasonably safely. And you need standardized reagents like standardized strains of RSV. And John DeVincenzo very kindly obtained a challenge virus called Memphis 37 that was being used quite widely. And we were able to obtain some of that virus. I think the other thing which really made us feel confident that we could do this was that we developed mucosal sampling methods based on trying to obtain fluid from the nasal mucosa, and we could do this very atraumatically. So this was my first clinical research fellow, Max Habibi, who started to do these studies in, I think, 2008. So I think we were encouraged to do this, actually, by some of the referees who looked at our Wellcome Trust application for a program. And we proposed to do more and more mouse studies, but we thought we'd throw in some human studies as well. They cut the grant, but they came back to us and they said, whatever you cut, you can't cut the human studies. So that, whoever you are, if you're out there, thank you. So it forced us into doing these human challenge studies. Initially, we did it in student accommodation during the summer when the students were on vacation, and we just commandeered some of the student accommodation and did it there. So the results were very intriguing in that there's sort of eclipse phase. Now, this isn't immunologically silent. There are things going on during this eclipse phase, but there's very little virus around. But it is really this stage that determines whether an individual goes on to become infected and to shed virus or not. So, exposure doesn't inevitably lead to infection and to symptoms. There is a path down which an individual will go, and if for some reason they are immune to the virus or to the consequences of viral infection, then they deviate from this standard expected pathway of exposure, infection, and symptoms. So it's what causes that deviation, really, which is so interesting. So this was one of the first studies that we did in adult volunteers, where we had 58 volunteers, all given this same Memphis virus, and 23 had a cold, 25 had no cold, and there were some in the middle that we could show virus replicating, but they were not symptomatic. So, what determines that variability? So we, rather than doing a placebo challenge, we did a challenge with a dose of virus that caused diverse outcomes and then looked at the causes of that diversity. So these studies are always throw up unexpected things. This was one of them. So when we did bronchoscopies on the volunteers, although they were perfectly well by day 28, quite a number of them showed really significant mucosal inflammation. And any of you used to doing bronchoscopies will recognize that this is a pretty inflamed mucosa. And we could also find RSV antigen in the mucosa. So I think, again, this is an insight which might lead to a better understanding of some of those delayed effects. So what was the cause of that diversity? Well, of course, the first thing that you might suspect would be that they had different prior antibody levels. So, all of us in this room have antibody levels. They vary. We have levels in our blood. We have levels in our nasal mucosa. So to what degree did that variability explain the variability in infection? So if you look at those who became infected versus those who were uninfected, this is nasal IgA. There's a significant difference, but it's certainly not causing that divergence into infected versus uninfected. If you look at the nasal anti-F IgA, then again there is a difference, but it's not explaining that diversity exactly. This is the serum neutralizing antibody, which really doesn't explain that divergence at all. So because these subjects were infected prospectively, we could take samples from the nasal mucosa and look at the pattern of gene activation prior to inoculation of the virus. So was there something different about the soil into which the virus was seeded? And indeed there was. So when we looked at the pattern of gene expression of those who went on to get a cold, so this is prior to any exposure to the challenge virus, versus those without a cold, there was a difference in gene expression. And when we looked at which clusters of genes were different between those who became infected and those who didn't, rather surprisingly, it was neutrophils. So if the subject had a neutrophil activation pattern in the gene signature from the nose prior to infection, they went on to develop a more severe cold. So that was completely unexpected. And the best science, I think, is unexpected science. Now, this shows what happens if you measure these mediators using these synthetic absorbative strips, these little nasal strips that we put into the anterior nose. And you can see that during this so-called negotiation period, prior to infection taking off, the subjects who become infected actually have a decline in the baseline levels of quite a few mediators. It's almost as if the mucosa is being lulled into sleep during this early phase. And then it takes off, and you can see all these mediators pouring out into the nasal fluid during the period of infection. So if the nasal mucosa mounts a slight response during this occult period, it suppresses infection. If the arrival of the virus is accompanied by a reduction in the baseline state of activation, then the virus succeeds. So, I think this was a surprising insight, and it's one which we're continuing to follow. So if we just look at exposure, what leads you down one path or another, nasal antibody seems quite important, but there's something about the mucosal tone which is important too, that we really haven't studied very much at all. During infection, the virus can induce damage and releases mediators, and we have cell infiltration. And in terms of clearance, T cells may be quite important downstream. So this is all very well, but it doesn't really lead us to understand what happens in those who perhaps are a little bit more vulnerable. We chose all of those subjects because they had no risk factors, and we knew they weren't going to get severe disease. Now, we knew that in mice, it had been shown by Barney Graham and others that old mice are more vulnerable to RSV infection than young mice. And this is quite a widespread finding. If we think back to COVID, age was the predominant risk factor for severe disease. If we think back to the time when improvements in hygiene was driving polio up the age range and causing infection in people who normally would have been infected as infants, and now they were meeting poliovirus for the first time as teenagers or young adults, the disease was a completely different disease with a very high rate of paralytic poliomyelitis. So we know that age per se is a big risk factor for many of these viruses. And we thought what we should do is to try and study this phenomenon of inflammaging or age-related disease severity. And we thought that it would now be ethical to go into older adults. This is a study which came out in Science reasonably recently. It's not on RSV, but I think it gives a nice background to thinking about how senescent cells lying within mucosal sites may cause a background of inflammation, which when augmented by viral infection, causes a very strong inflammatory response. Whereas with a non-senescent mucosa with no senescent cells, this response causes less dramatic effects. So we called our study Inflammage, and I keep having to tell people it's not inflammage, it's inflammage. And this was a new model of funding which was set up actually by the UK government because they wanted to encourage co-funding with industry. And so GSK agreed to join with 5 different UK universities in this Eminent consortium, as it's called. And one of the first programs that was funded by Eminent was actually our Inflammage study. And here's the same picture. This actually was not Max doing this study this time, but this was the same sort of study which was done in older adults. So here we've got these older adults, so age 61 to 73, compared to a historical group here of younger adults. And you can see that actually the infection rate is higher, if anything, so 77%. And the rate of symptomatic disease is also very high in these normal, healthy older adults. If we look at the symptoms, then actually the young adults have quite mild symptoms. The older adults have generally rather higher symptoms, and they persist for longer. And also the virus load is higher in these older adults. So what about the correlates of protection? I think it's intriguing that although the numbers are very low here, the number who were uninfected was very small, but actually those happened to be the individuals who had prior high levels of antibody, which I think again feeds into the narrative that boosting these levels of antibody in older adults with vaccines might be beneficial. We also have a hint here that the young adults tend to develop better nasal IgA responses, whereas the responses in the older adults were pretty flat. So these were huge collaborative studies, and I particularly like to, say that Chris Chu is really the one. This is Chris. Chris is the one who is really running these studies now. This is Pete, who is the clinical research fellow who's funded by Inflammage and by the Eminent Consortium, and some collaborators from GSK who've been very helpful, particularly in terms of some of the data analysis. So that's really the story which has taken me from an interest in inflammation in patients into mice and now back into volunteers. And I just wanted to mention at the end this HICVAC consortium that we have, again funded by the UK, to try and enhance the development of vaccines and treatments for infections, particularly in low and middle income countries. And that we've actually got a very large number of members of this consortium now, and we're hoping to try and get further funding to continue it. And I guess this is my last reflection, which is that so much that we learnt during our studies, first in mice and then in humans, of RSV, have been enormously influential in the rapid understanding of what happens when a relatively new virus comes into a human population in terms of SARS-CoV-2 and COVID. I think a lot of what we've learnt here in terms of a viral phase followed by an inflammatory phase, reflects what we understood from all those studies that we did in RSV. And I think in terms of the treatments that have come out as most effective, particularly for the more severe patients, they are largely immunological. It's been a little bit disappointing how much antivirals, how little antivirals have contributed. And the importance of the immune response in causing disease is quite remarkable. And I'd finish there and just like to thank Resvinet again for their great generosity in asking me to come and talk. Thank you. So I don't know, are we having questions? Yeah.
Thank you very much. Great talk, but this is no surprise. I think we have 5 minutes for a quick question and answer session. So if any one of you want to ask anything, please stand up and go to the 2 microphones. Say who you are and ask. Please, Peter.
Hi, Peter. Matthew Snape here from Moderna. This is a RSV conference, and I'm reading the title up there that says Global Conference on Prevention and Therapeutic Interventions. And when you look at what's being presented, it's almost all about vaccines and prevention, not therapies. Your findings here suggest that really and the experience from SARS-CoV-2, that chasing therapeutics for RSV infections is a lost cause?
No, I don't think a lost cause at all. I mean, yourself as a pediatrician will know that we'd love to have something better to use in people with inflammation, which is not steroid responsive. You know, there have been so many trials of interventions with steroids, very blunt instruments immunologically, and there's a whole class of diseases which do not respond. I think what we'd all like to do is to be able to pinpoint the intervention which is going to work based on scientific study. And I do think actually that experience with COVID will feed through into the discovery of specific immunointerventions of the sort that you and I would love to see.
Peter, lovely talk. You showed that in the vaccinia system, either vector G or vector F could lead to enhancement after challenge. Sort of fast forwarding to today, how do you summarize the mechanism of enhancement?
Okay, yeah, so a lot of work's been done on the mechanism of that FI-RSV enhancement, and whether this relates to that, I'm a little bit cautious. I mean, I think the induction of a powerful cellular immune response in the absence of a good protective neutralizing response is pretty consistently observed. I mean, in all the animal models where it's been done, formalin inactivated RSV induces a sort of eosinophilic type response. It tends to form a Th2 response, but not exclusively. But I would say that a lot of the augmentation of disease is related to strong priming of cellular immunity in the absence of good neutralization. I hope that fits with your feelings, Marty.
Yeah, absolutely.
Yeah.
Thanks, Peter. Of course, I laughed your last slide best. Of course, can't help it. You mentioned that the cells in the blood are a pale reflection of what's happening at the mucosal level, and that's why you study mucosal immune cells. And then you discussed antibodies, and you discussed serum neutralizing antibodies, but why shouldn't we, so maybe you can reflect on how pale serum neutralizing activity reflects neutralizing activity of antibodies at the mucosal level. Are we sufficiently able to measure a neutralization by antibodies at the mucosal level?
Yeah, I think all of us mucosal immunologists, and I would count myself as a mucosal immunologist, and would love to see mucosal vaccines that stimulate good protective responses in the mucosa that prevent not only the serious disease, disseminated disease, serious lower respiratory tract disease, but also prevent nasal replication and transmission of virus. I mean, it does seem, we've just published a paper on nasal antibody compared to systemic antibody in people who've recovered from severe COVID, who have then gone on to be vaccinated, and show that peripheral intramuscular vaccination gives a very good boost to systemic antibody, does virtually nothing in terms of the mucosal antibody. But I think we now have the tools to measure mucosal antibody, and we need to redouble our efforts to try to focus the immune system on the mucosal site, most easily, of course, through live attenuated vaccines, but there are various other ways that might do that as well. Okay.
Thank you, Peter.
Last question.
Last question. You showed the neutrophilic response associated with more severe disease. What do you think the role of the respiratory microbiota or microbiome plays on those responses?
Yeah, I think the microbiome is absolutely vital to study. Unfortunately, I think the size of study that would be needed to understand the contribution of the microbiome was probably larger than the study that we did. And the ways that we tried to study the microbiome are probably about 10 or 15 years out of date. I think with up-to-date methods of studying the microbiome, we might now be able to find out what it is which is stimulating that airway neutrophilia. Yeah.
Thank you.
Thank you very much. Please join me in thanking Professor Openshaw. And now I have the pleasure to invite the two chairpersons of the next session to take the stage and open their session. Thank you.
Good afternoon, everybody. It's my great pleasure to be here and welcome all of you to what is really going to be 2.5 days of exciting science at a time of, I think, we're a bit of a watershed moment for RSV, thinking about the science and the tools we have. And this session is really here to set the scene for the next 2 days, where we're also looking at what these tools can achieve. And in order to ultimately show their impact, we need to be aware where the burden is and how it can be addressed in all settings in the world. And that has a perspective on big data that are being collected and are going to be presented here today, but also the perspective of the patient, because ultimately we're here to address a disease that affects people, and it affects young babies and affects elder people in particular. So it's my great pleasure to welcome you and chair this session with Professor Cheryl Cohen. My name is Beate Kampmann. I'm a clinician scientist in pediatric infectious diseases. We have 2 parts to this session, which is interrupted by a short break, and we'll have 3 speakers first of 15 minutes each, and then 5 minutes per talk on some questions if they arise. So without further ado, I'd really like to welcome our first speaker, who will represent the parent perspective. And I think it's particularly important for lots of us who do bench science, because to see young babies and suffering on intensive care units and in pediatric wards that are overwhelmed by infectious children with RSV every year, every winter, is really a very important experience, which as clinicians we have all the time, but as bench scientists we don't often see. And yet the science that we do at the bench really makes a massive impact. Otherwise we wouldn't be here having vaccines and monoclonal antibodies. So if I may ask our parent representative, and that is Brenda Resvinet, who will tell us how RSV is featured in her life and also in the parent advocacy group. And this is a really important part of the symposium, so thank you very much for representing that part.
Thank you. Can I just
go ahead?
Hello, I'm Brenda. I'm a mother of 4, and since last year I'm a member of the Patient Advisory Board and of the PAP. And I will share with you the story of my 3rd son, Thomas, who got infected with RSV when he was 3 weeks old. Thomas was born at the end of November 2019. He was my 3rd child, and he was born with 38 weeks and 4 days. He had a healthy weight and he was born healthy. After a very quick birth, he suffered from wet lungs, but after 2 days we got out of the hospital and everything was fine. He was being breastfed. Although he was my 3rd child, I had never heard of RSV until a week before he got sick. Afterwards, I see so many options to start with the midwives during pregnancy, or the consultation office, the maternity care, or the GPs. It can be as simple as a folder. A week before Thomas got sick, I saw an item on the news about RSV. The hospitals had an overload of RSV patients, which was a severe cold virus, which can even be fatal in the most severe cases. There was a short reflection moment. I hope my children won't get sick. However, when he was 3 weeks old, he got sick. His brother had a cold and an ear infection, and despite the fact that we were very cautious, Thomas got infected as well. When he was 3 weeks old, I went to the GP with him because we had a very bad night. I had already tried all my tricks, but that night he had a lot of trouble with his drinking. He had breathing problems because of a stuffy nose, and all my tricks didn't work. So I went to the GP and I told him I had a bad feeling about this. The doctor told me it was just a common cold. We had to watch for a fever. When he had a fever, we would have to contact again, but otherwise he advised us to just use a nasal spray before the feeding moments and just watch him. Remembering the news item, I asked him about RSV and the warning signals. He told us, watch for the flaring nostrils and for turning blue around the nose and the fever. The next day, I went to the weekend GP because the breathing sounds were worse. His temperature was now 37.7, and he had a very strange cry. It was more like a scream. So again, I told the doctor, I have a very bad feeling about this. And again, I asked about RSV. However, I have been sent home again with the same story. It's just a cold. According to this doctor, RSV was also just a common cold, and only in the rare cases, children have to be admitted to the hospital. So he said, watch for the nostrils and turning blue around the nose and the fever. However, Thomas did not ever show any of these signals. That day, he started falling asleep and he slept a lot. So first I was relieved. Finally, he would get some rest, but he did not wake up for his feeding moments, so I had to wake him up every time. And that night, I had a very bad feeling because when I tried to wake him up, he didn't wake up for more than a couple of seconds. After being sent home twice, you start doubting yourself. His temperature was still the same, so there was no fever, there were no nasal flaring, and he was not blue around the nose, although he seemed a bit gray to me. It was my feeling that made me call the doctor again. They sent a GP to us, and the GP immediately called for an ambulance. Just in time, because in the ambulance, Thomas stopped breathing again and again, and we had to shake him repeatedly to get him going again. When we were in the hospital, he was so weak that there was only one scream, although the doctors needed several attempts to put in an IV. They tried everything to help his breathing, but his condition got worse, and the same night he got intubated and transferred to the Wilhelmina Children's Hospital in Utrecht. The first few days were very bad. His condition got worse and he needed a heart massage. After 1.5 weeks, they tried to get him off the ventilator, but unfortunately this did not work, and he was in the ICU for 3 weeks. After that, he got transferred to medium care because his medicines, like morphine, had to be reduced under supervision. As parents, we experienced a standard policy to get children at home as soon as possible. Don't forget, parents want to leave the hospital as soon as possible too, but also as good as possible. The standard, in our experience, the standard policy or the standard reduction schedules come first. Decisions are made without any consultation of the parents, and they just decide anything. As a mother watching my son for almost the entire day, I saw my son struggling. I saw that the reduction went too fast, and I told the doctors, but I felt not taken seriously and being labeled as overprotective parent from the ICU. Action was only taken when the numbers like the heart rate or the oxygen level indeed went down. I am convinced that we have to work together, that doctors should consult with parents, because protocols are based on numbers, but patients are not numbers. You, as doctors, as researchers, as policymakers, you know the numbers, but we, as parents, we know our child. These are your patients. We have to work together in order to improve healthcare. After 2 more weeks, Thomas was being sent home, but out of the hospital is out of sight. So many parents are left in the dark about what to expect. This is also not clear for their family and friends. Everyone around you seems to think everything is okay now, you're out of the hospital. However, it's just the start of recovering from this experience. You have to leave an environment, a safe environment, with the help of doctors and nurses, and you have to start to trust yourself and your child, and to trust that he is recovering, although you see him struggling. And many children continue to have problems with their lungs. They cough a lot, and they need medicines. As young as Thomas was, he was 8 weeks when he was out of the hospital. He was very restless and easily scared at home. Especially when you came near his face, he was very scared. For his brother and sister, it was difficult when they just wanted to play, and for us as parents, it was a struggle to wipe his mouth or nose. It lasted for more than a half a year. He was afraid of strangers, especially when they wore a mouth mask. And then came COVID-19, so you can imagine the struggles. He had a lot of trouble with his sleeping. Mentally, he needed to be close to me. Physically, he needed to be kept upright. So I walked many, many miles with him for many, many nights, just keeping him upright. He had trouble swallowing and with his breathing during crying, especially during crying. And we often raised these problems to the doctors, but they brushed them aside. So many babies have sleeping problems, and children develop in their own pace. And again, we were felt we were not taken seriously. We kept trying, and when he was almost 1, he got referred to a lung specialist who got him medicines which really helped. He's 3 years old now. He's a big brother and he's doing okay, although he still suffers from the aftermath of RSV. He needs speech therapy for his mouth mobility and for his breathing techniques. He needs his medicines on a daily basis. We waited with daycare until he was 2.5 years old. Until that time, I did not work. I worked minimal from home to take care of him and the other children. Since he started daycare, he suffers from a cold on a regular basis. And for him, it's not the same compared to his siblings. As you can see, he often lies lifeless on the corner of the couch, just needing his energy for his breathing. We also have noticed that he is often too tired to cough effectively, which means that it takes longer to recover. And with every cold he has his difficulty sleeping. So the sleeping problems are really breathing related. As parents, we feel like we have to watch him ourselves. Doctors, in our experience, doctors do not act until the numbers tell them to act. So for a long time, I didn't trust any doctor. I realize now that this is not correct, but I try to rebuild this trust. But I still rely on my own feelings the most. Sometimes when I'm in doubt on the Fridays, we go to the GP to check his lungs. But most of the time, we rely on our own skills and tricks and on the inhalers. During my stay in the hospital, Lies Kriek, back then a research nurse and now chair of the PAP, contacted us whether we wanted to participate in the rescue project. We did because we wanted to contribute to research into a vaccine. We stayed in touch, and since last year I'm a member of the PAP because I want to help raise awareness. I want to prevent other families going to the same story. I want professionals to know about RSV, to know the signals, to know the warning signals, but to also realize that they do not always show these signals. I want all parents to know about RSV. I don't want to scare them. It can be just a cold, and for most of babies it will be, for most children it will be, but for the most fragile and the youngest children it can be so much more, and they really need to realize. This is also very important now that the vaccinations are nearly there, because why should you vaccinate yourself or your baby when you don't know anything about RSV, or when all you know is what the GP tells you, it's just a cold. One other important aspect of the PAP is the peer support. As a parent, you can feel very lonely, scared or helpless when your child is sick, especially when you have the feeling that the doctors won't take you seriously and won't listen to you. In the hospital, I saw other parents going through the same struggles, and talking to each other helped. Although no story is the same, you can feel each other and just support each other. However, when you're back home, that contact falls away and you are back alone again. Especially during COVID, I had many lonely moments with helpless, anxious and depressed thoughts. I really missed the peer contact. Through the PAP, I learned of the existence of special Facebook groups for our target group, and it's really a great concept. Parents from all over the world share their stories, have contact with each other, and just support each other. You are not alone. You feel better understood. You are not going crazy. Other parents feel the same way too. Last year, some parents of the PAP contributed to a course of the University of Utrecht, Hospital Communication, in which students have to come up with a solution for a hospital communication problem. Together with my group of students, we have developed a picture book of RSV for children. It helps children to understand the situation of their sick brother or sister, and it helps parents or other adults to start a conversation about their feelings. My own children actually helped developing this book and came up with advice from their own experience, like there should be a picture of all the sad people because everyone who came to visit was sad and some even started crying. There will be examples in the hall. However, we have noticed that some of them are missing. These are really examples, so please return them. Then we can show everyone. For me personally, it's also very important to raise awareness for everyone. Research focuses mainly on high-income countries. Vaccinations will be available in high-income countries, but the high mortality rates are mainly found in the low and middle-income countries. What about them? Thomas just survived because an ambulance was there within minutes. However, these children most of the time don't even get access to a doctor. I hope that raising awareness will help reducing these numbers because parents will seek help faster when they know about the risks. Also, I hope that the vaccinations will be available for these countries too, and I would like to call attention to this. So we really need to raise awareness of RSV for everyone. Parents need to know about all the risks, and they need to realize about what RSV is. Professionals need to know about RSV. They need education. They need to know the warning signals, but also need to realize that not all babies show these warning signals. They should to take into account all information, which leads me to the third point. As a pup, we learn other parents to follow their feelings. Now it's time that the professionals start listening to our feelings and just take us seriously. This was my story, but I am a member of the PUP, and we are here together with a group of 6 parents, and from all different countries, and we all have our own stories. We are not here to scare everyone or to point fingers or whatever. As I told you, we have to work together, and we are here to do just that. We are here to speak to each other, to learn from each other. So we have a stand in the hallway, just below the stairs. You cannot miss it. And we will be there till Friday. So let's talk. Thank you.
Thank you. Thank you very much, Brenda, for this very moving description of what will resonate with many people in the room, I guess, who are also parents and whose children might have ever been sick with whatever disease it was, because it's a shared experience. And I think the fact that RSV is so poorly recognized is really a big deal, especially in countries where diagnostics are not easily available. Yeah. Are there questions? First thing, your book must be a rampant success because copies have already gone missing, so please return the copies.
We hope they will be everywhere, but for now they need to be on the table.
If there are no questions, are there thoughts about extending the initiatives from this, what looks a bit like a European parent initiative, to low and middle income settings? And maybe you can reflect a little bit on that. And also, I noticed there are a whole group of women on your slides. Yeah. But where are the fathers?
They are back home watching our children, so they are there. Okay. But most of us, the mothers speak better than the fathers, but they are here watching our children. So they are in the picture. So they have the same story, and I already told my husband, so it's also his story. So yeah. I put him in the pictures.
Yeah, just from the international perspective, sometimes fathers and the male parts of the family are also an important opinion leader in the family when medical care is sought, etc. And if we give them visibility also in the materials that we produce, that's also maybe a good thing to sort of think ahead when you do your next book. Any questions come up in the meantime? Otherwise, we proceed from the very personal to the very global. And yeah. Thank you. I can't see any questions. Thank you very much. So what we've just heard from Brenda obviously happens on a global scale. And if I might invite Mohsen to come forward and give his presentation on the worldwide burden of RSV disease. Is he around? Mohsen Nagavi? Coming, great. I probably did a bad job with your first name. I'm sorry if that was terrible. You need to put me right.
Thank you so much. Thank you. My name is Mohsen, and I am professor of the health metric science in the University of Washington. And usually in the Institute of Health Metric and Evaluation, we calculate global burden of disease. That is a process that every year we are doing. And in the global burden of disease, we calculate pathogen for the different infectious syndrome, including lower respiratory disease, lower respiratory infections. Okay. We calculate RSV in the context of the lower respiratory. And we try to calculate what is the number of the deaths and number of the cases. we calculate number of deaths and also deaths due to the RSV and also VLL. It means that years that we lost due to the premature deaths for the RSV and other diseases. We calculate number of the cases, incident cases, and also in addition we calculate the years that we lost due to the disability due to the diseases. And by the end, we calculate DALYs, that is combination of the number that we lose due to the premature deaths and number that we lose due to the disability for the incident cases. Okay, in this picture, I will show summary of the different indicator for the RSV in the all ages, under 5 and under 1. Okay, this is for 2019. As you see, we have in the all ages, we had 400 million cases. And in the under 5, 45 million lower respiratory and 9 million lower respiratory. And RSV, in all ages, we have 15 million cases in 2019. Do not consider COVID as a routine process. If we do not have COVID, usually we have this number, 19 million cases. In under 5 will be 7 million, and in under 1 will be around 2 million. From this number, and please look to this, that when we decrease, when we are in the younger ages, incidence of the RSV is much higher in the comparison with the other pathogen. Now look to the deaths. We have 2 million deaths due to the lower respiratory in all ages. Maybe this is a number that you need. 87,000 deaths is due to the RSV in all ages. Every year, do not consider COVID as an interventor. This will be 71,000 in the under 5, and in the under 1 will be 55,000. In other words, if we have vaccine, a good vaccine, we can prevent every year 87,000 deaths. And this is a very big achievement. And this is combination of the incidence and prevalence. And you can see with any going to the younger ages, fraction of the RSV in the lower respiratory will increase. It means that, okay, this is a fatal death in the children. Okay. If we look to the context of the other pathogen in the lower respiratory, you will see that, okay, you should follow these 3 colors in all of the slide. Red one is RSV, green one is flu, and yellow one is other virus in the lower respiratory. Please consider I am talking about just lower respiratory, not upper respiratory. And you can see this is the age pattern for the different pathogen in the lower respiratory. This is cases. Sorry, maybe we should come back. This is deaths. This was deaths. This is cases. You can see cases is much smaller in the young age, but it is much fatal. And this is DALIs. Now you can see that why we calculated the years that we lost. When we calculate the years that we lost, we could show much better effect of these diseases in the young age. What is the DALIs, both disability and premature deaths? By the age, you can see the biggest effect is in the under 5. Because with the dying of the kid in age 3, we lose a big time. But when dying in age 86, we lose not a lot of age. Because when we calculate YLL, we compare with the standard life expectancy. A standard life expectancy is the life expectancy that expectation is that people have this life or die in this age. And it is one life expectancy for men, women, rich, poor, everything is the same. Okay, now look to this. It is combination of the DALIs, deaths, and incidents with the different pathogen in the lower respiratory. If we want to see carefully, I sorted based on the DALIs. It is in the, I think that, yes, it is in the all ages. And if you look to this, you can see that the RSV is one of the most important causes of the lower respiratory. Okay. Now, this is death rates and DALIs rate. Again, the biggest problem is in the under 1 that the mother showed a few minutes ago here. This is fraction, maybe is not very interesting for you, but it is epidemiologically, this is an important topic for us. And this is comparison between flu, RSV, and other deaths, age-specific death rate for these 3 important viruses. You can see here that RSV in the under 1 and 1 to 4 is the biggest topic. We have to be very serious about these pathogens. As usual, everything is for the poor area. Sub-Saharan Africa has the highest rate of the deaths in the here in comparison with all other regions. In fact, any vaccine can help and keep alive poor people that doesn't have a good treatment. And this is death rate for under 1. Oh, sorry. This was death rate for the 1 to 4, and this is death rate to the under 1. And you can see here Okay. It was some distribution of the RSV in the lower respiratory in the different area, age, location. Let's look, all of this is rate, age-adjusted rate. It is 1 to 4. Okay, now look to the time trend. Time trend of, as you see, time trend, okay, time trend of the sub-Saharan Africa is decreasing, but it is much, much higher than any other region. And then came to the Pakistan, India, Bangladesh, South Asia. Yes, it is correct that globally we decreased this number from 21 to the 10 in the globally. But again, you can see there is a big disparity between different regions due to the RSV. Then again, RSV is a big problem. I want to say that in the duration of the COVID, we forgot about RSV. But if we look to the time trend, we will see. And this is 1 to 4, same pattern. And this is under 1, same pattern. In all the pattern that you see, Sub-Saharan Africa, South Asia is the highest. And then global and other region, especially high income, nothing. It's not a comparable with the other country. Okay, this is country distribution for RSV for under 5. And you see that there is a big distribution, big discrepancy between high income and in the low income. Highest that we can see is in Nigeria, in north of Nigeria, Afghanistan, and Pakistan. These are the highest rate that we have for it's different by year, but more or less is the same. The big question that now you have, okay, this is 2019. What happened to the 2020 and 2021? That is a very good question. Honestly, I cannot answer 100% to the 2021. Let me come back. Look to this number. This is rate of deaths for the under 5. And this one, it is rate 60, that is here. It is 60 for the 2020. There was a big competition between COVID and RSV. For any reason, I don't want to go to that. But our data is not finished. Our analyzing is not finished for the 2020 and 2021. This is very primary result that we have. Yes, there is a big decreasing, but there was a rebound There is a rebound. We don't think that a story is finished. There is a rebound, and in the rebound process that happened 6 months or 1 year or 2 years after lockdown or after mobility, we will have a big increase for the RSV. But we have to wait until 4 or 5 months that we can get better data and finalize our result by the country age 6 for the different country, including RSV. And thank you so much. I am happy to answer any question, comment.
Thank you very much. Are there questions?
Hello, I have a question. Thank you very much. Hema Sharma from AstraZeneca. So if you wouldn't mind just going back to your slide where you've shown the decline in the incidence of the infections by the regions, please.
Say that again.
You have a slide where you showed a decline in the reported number of cases by different regions over approximately 20 years. And I would just like to understand whether you could comment on what you think the reason might be for that decline in countries that are not so developed, please.
Thank you. This was that I showed, it was not cases, it was deaths. For sure, from 1990 until 2019, our care, our situation, our hospital work better. Then there are some decreasing in the number of the deaths, in the rate of the deaths, comparison with the other diseases. But again, cases is very high. And fraction of the cases that goes from outpatient to inpatient and from inpatient to the deaths is decreasing, but not at all. We need something to prevent this disease. We do not need just treatment. We need prevention. Thank you.
Another question?
Hi, Mohsen. My name is Leila Krachten, and I was actually curious about how did you collect the data, right? So your sources, because we know that in many countries, RSV testing is actually not being done. So can you comment on that?
The best question. Thank you. Yes, GBD, global burden of disease, and antimicrobial resistance are the systematic and scientific review all the data that is available. Let me put one number just for you. For the antimicrobial resistance, that RSV, we calculated in this area based on the pathogen distribution. We know that there is no resistance. We gathered 450 million test results. We have more than a 3 billion record of the hospital individual record in the different age from the different countries. We are gathering all of the literature, all of the publication. We do literature review for every year for all the publication that is related to the incidence mortality. We gathered data for the mortality from every year. Every year we have around 55 million deaths in the world. We gathered vital registration data, more than 25 million deaths from all ages. We are using verbal autopsy, and anyway, we are very weak in the RSV. Then really we need, especially RSV for us, the part that is hidden, it is morbidity, subclinical, and outpatient level. When the kids go to the hospital anyway, we can get this data. But
provided their diagnostics. Shall we move on, because there's a couple more questions before we run out of time? I think, yeah, no, it's fine. The lady over there.
This is Gigi Zhezheng from Yale University. I have a continual questions about the previous one. So how do you control for the reporting difference between region when you collect this systematic?
Okay, as I said, we gathered all of the data from all of the region. Especially, we do not have a good data in the low-income region. We have better data in the high income. And we have a modeling process that based on the different data from the location with the covariate and with the borrow strength from the other country that we have data, we have estimation.
Thank you.
Hello.
Hello.
Karina Ribeiro, epidemiologist from Sanofi in Brazil. Thanks for the presentation. I wondered that if you could comment a little bit about codes used to classify RSV disease, because literature is showing that the burden can be even higher if you consider that most of the unspecified bronchiolitis among children under 1 are actually RSV cases, but they are not coded with an ICD code of RSV case, and also deaths.
That is a very good question. Let's go to Brazil now. You have data from all the hospital data, CINAN data. And this CINAN data cover 85% of your population. In the CINAN data, that it is for the billing process, your doctor have to mention type of lower respiratory in the children by the different pathogen. If he or she clarified that this lower respiratory was due to the respiratory, he can get correct money. In fact, we are using your data in the different age group in the CINAN for getting this result by the region for the different state in Brazil. Because you do not have outpatient result, outpatient data, we cannot have a very good estimation for the outpatient. But we have a good data in the inpatient, and we get this data from the CINAN data that you have. Did I answer your question?
More or less, just to know if when you use for GBD, if you include the unspecified bronchiolitis or not.
Unspecified RSV or unspecified lower?
No, unspecified bronchiolitis.
Okay. We drop unspecified lower respiratory when we calculate for the pathogen. We just include for the lower respiratory if the pathogen is clear. We do not get from unspecified.
Perfect. Thank you.
Thank you.
Thank you. Last question. We'll need to be done in the next 2 minutes, please.
Just a quick comment. John Paget from the Netherlands. So there are other groups out there making burden estimates. I think when you give the IHME presentations, it would be good to compare your estimates with other groups, for example, the estimates made by the University of Edinburgh, so that we can sort of judge the different outcomes and how they vary, because there's a lot of variability in these estimates as well. Just a general comment.
Thank you so much. We are, all of the time, we are happy to compare our result with all other. But anyway, our result is online, publicly available in the GBD Compare, and everybody can look at what is our estimation. You can get exact this map from the internet, just type GBD, and you can get all of these results, and you can compare. We try to compare our result with every publication. If I didn't see your result, this is my mistake. I will try to see your result and compare.
Thanks very much, Mohsen, and I suggest that you guys having dinner together tonight, because there's obviously, and anyone else who wants to query the methodology of how these data are collected. So thank you very much. So we now have the opportunity to listen to another way of collecting the data and presenting in, particularly the data on mortality in children. And may I ask Yvette to come and present the data from the RSV Gold project, please. There you are, good. This is a preliminary data presentation, but we will be keen to hear. Thank you.
So thank you so much for the opportunity to speak here at this global conference. I'm Yvette Leuenstein. I'm a PhD candidate in the RSV research group of Professor Louis Bond, but I'm standing here on behalf of a great team, and I'm happy to share with you the preliminary results of the RSV Gold ICU network study, which is part of the RSV Gold project. The study is funded by the Bill Melinda Gates Foundation, to which we are very grateful. For those of you who have not heard of RSV Gold yet, I will shortly introduce the project. GOLD stands for Global Online Mortality Database, and the RSV Gold database is the first global registry of children under the age of 5 years who have died with acute lower respiratory infection due to RSV. It was set up by my former colleague Nienke Scheltema in 2015, and she contacted researchers and pediatricians as yourselves all over the world to ask them to share data. Because our vision is that global data sharing is required to get insight into the risk factors for pediatric RSV-related mortality, as mortality is a relatively rare event. We aim to understand the clinical and socioeconomic characteristics of children under the age of 5 with RSV-related mortality. And eventually, of course, we want to make an impact. We want to use our data to create global awareness among pediatricians and among parents and among policymakers. These are some of our findings that we have published in the last years. The first global case series was published in 2017 in the Lancet Global Health. We captured data of 358 RSV-related deaths in children under the age of 5 from 23 countries all over the world. What we found is that most RSV-related deaths occur in the younger children. 70% was younger than 6 months of age. And for those children dying in high-income countries with RSV, most of them had a comorbidity, such as congenital heart disease or chronic lung disease or an immune disorder. We've also published a report on children with Down syndrome and RSV-related death. We collected information about 32 children with Down syndrome and RSV-related death from 20 countries. And we found that 1 in 4 children with Down syndrome did not have any other significant risk factor for severe RSV disease, such as congenital heart disease. So we concluded that Down syndrome is an independent and important risk factor for RSV-related death. 2 years ago, we got the great opportunity to pull data from the Gates-funded RSV-related community mortality studies. And we collected data on 663 in-hospital and 166 community deaths from 35 lower middle-income countries. We found that in community deaths, so those children dying in the community with RSV, are generally younger than children dying in the hospital. Last month, we published our last results on children with hospital-acquired RSV infection, so nosocomial deaths. We compared children who acquired RSV in the community to children who acquired RSV in the hospital, and we found that age of death was similar for both groups. And we also found that nosocomial RSV was rarely reported in low and lower middle income countries. So we need more data on that. So just in summary, RSV Gold captures data on children under the age of 5 with in-hospital death, but also in-community death, children with hospital-acquired and community-acquired RSV-related death. And thus far, our data have been collected retrospectively. But now we are conducting a study, of which I will tell you more about in a few minutes, that is actually collecting prospective real-time data of children dying with RSV infection in low and lower middle income countries. And this study is called the ICU Network Study. And we aim to collect data on the burden of severe RSV disease in low and lower middle income countries. Our primary objective is to describe the clinical and socioeconomic characteristics in children under the age of 2 who are admitted with severe respiratory disease and severe RSV infection in Gavi-eligible countries. And we hypothesized that RSV is a major cause of respiratory illness in these children who are admitted to the ICU with respiratory infection. We started the study up in 10 low and lower middle income countries, and we aimed for a global distribution, so we are conducting the study in South America as well as countries in Africa as well as countries in Southeast Asia. We aim to collect data on a total of 4,000 children admitted to the intensive care unit, and the study takes place for 2 consecutive years, so 2 consecutive respiratory seasons. Of course, we want to describe the burden of disease. This will be important information for policymakers and also to create awareness. And we would like to identify risk factors for RSV mortality because that information is important for vaccine implementation programs. It's actually quite a simple study. In 7 study sites, so in 7 low and lower middle income countries, we collect data on children who are admitted with suspected RSV infection to the intensive care unit. What do we mean with suspected? We mean those children who meet the extended SARI case definition criteria from the WHO. In 3 study sites, we also collect data on children that are admitted for a different reason to the intensive care unit. So they don't have any respiratory symptoms. They might be admitted for other problems, gastrointestinal problems, for example. We, of course, collect parental consent and then take a nasopharyngeal swab. And we use a point-of-care test machine that gives a result in 15 minutes. And in 2 countries, we also perform PCR validation. So those countries are Ghana and Sudan. One of our students, Marin Bond, who is actually here at the conference, performed a pilot study in Ghana together with our friend Eva Obadai, who's also here at this conference, to look at the concordance of both the PCR and the molecular-based point-of-care test. That concordance rate was about 93%. That was quite high. So for those children who test RSV positive, we collect clinical information and patient characteristics, and we also take a parental questionnaire. And we ask questions about living conditions, distance from the hospital to their homes, access to medical care, and also about awareness from the parents. Have they ever heard of RSV infection? The study protocol has been published in the BMC Infectious Diseases in 2020. These are our study sites that are participating in the study. Actually, our collaborators in Nepal are very enthusiastic, and we have 2 hospitals participating in Nepal. So we are in the Korlibu Teaching Hospital in Ghana, in the Kanti Children's Hospital and the Tribhuvan University Teaching Hospital in Nepal. We are in Maputo Central Hospital in Mozambique, in Ahmadu Bello University Teaching Hospital in Nigeria, the Muhimbili National Hospital in Tanzania, the Edward Francis Small Teaching Hospital in the Gambia, the Ghaffar Ibn Auf Specialized Hospital for Children in Sudan, the La Quintanille Hospital in Cameroon, St. Damien Pediatric Hospital in Haiti, and the Hospital de Niños Dr. Mario Ortiz Suarez in Bolivia. And yeah, I'm actually very happy with this great team. Of course, we had to provide training to our study collaborators, and we actually visited the study sites. We have some nice pictures here of Lieke Kamdi, who's also here at the conference, who visited the team in the Gambia and had a very warm welcome and provided some training as well. Marin here in Ghana, testing the point-of-care machine. Tricia, who's also here today, visiting the team in Cameroon on the lower side here on the slide. And I actually visited Bolivia and explained how the machine worked. But also COVID was there, and some political situations in the countries participating didn't allow for us to visit. So we also provided online training via Zoom, and of course we had to see whether that would work out, but it actually did. So these are some preliminary results of the study. These are data from the end of January, so we are a bit further now, but we have screened a total of 1,934 patients, and 499 of them were RSV positive. So that is 26%, which is quite high. The RSV positivity rate ranges between 21 and 39% for each of the participating countries, as you can see here. And we've had some seasonal variation as well. We saw in the first respiratory season that the RSV positivity rate was a bit higher, and in the second season that it was about 20%, and that may have to do with the shift in RSV seasonality post-COVID. And we have a nice poster on that here in the conference from my colleague Nele Raven. These are the number of RSV positive patients included during the study period. And you see here that we have most cases from Nepal. And when you look at the two groups separately, so those children admitted with suspected RSV infection, so those who are meeting the WHO extended SARI case definition, the RSV positivity rate is not surprisingly higher. In the group children that didn't have any respiratory symptoms but were admitted to the intensive care unit, the RSV positivity rate was only 3%. So these are some baseline patient characteristics that may be interesting for you. The median age at testing was 3 months. We see that the majority of children was below the age of 6 months. Gestational age in weeks was 38, and only 12% of the children were born prematurely. 15% had at least one comorbidity, such as congenital heart disease, and that was also the most commonly seen comorbidity in these children. And there's a median length of hospitalization of 1 week. And there's also an interesting story of one of our collaborators from Nigeria who mentioned that there are some cultural differences from parents answering the parental questionnaire. Because when she asked how many days the child was having symptoms, they would always answer 2 days, even if it was a week. So she really had to ask more in depth about the complaints. What's also important to mention, I think, is the maternal tetanus immunization rate. That's quite high, 93%. So that may also have implications for implementing maternal RSV vaccines. Strikingly, parental RSV awareness was only 2%. Our collaborators from Nepal mentioned that parents didn't really have background information about RSV. They usually thought that their child had a bacterial pneumonia. Our case fatality rate was 5%. And the age at death in months was the same as the age at testing, so it was 3 months median. And at the right, you could also see the age distribution for the children who tested RSV positive above. and for those RSV positive deaths. And you see that the majority is on the lower spectrum of the age difference. So these are our key takeaways that I want to give to you. RSV infection is associated with 1/3 of respiratory-related ICU admissions in children under the age of 2 years in these low and lower middle income countries. RSV-related mortality was 5%, and the median age is 3 months. So that indicates that maternal RSV vaccination and other prevention RSV antibodies could have a major impact on preventing severe RSV disease in low and lower middle income countries. Steps for the future include a health economic study, which is conducted by my colleagues Nele Rave and Farina Shaban in collaboration with PATH. They will measure cost of illness and cost effectiveness in 5 of the low and lower middle income countries of this study, which are Mozambique, Nepal, Cameroon, Ghana, and Nigeria. Furthermore, we would like to perform country-specific burden of disease analysis to estimate the burden of severe RSV infection in different regions. And we would like to use the WHO manual on estimating disease burden together with local census data. And we actually have some nice posters on this topic at the conference. Lastly, my colleague Joukje Willemse, who is also here, is developing a vaccine impact model using the RSV GOLD data to make country-specific predictions for vaccine efficacy. This study is not possible without the huge effort of this group of people, so I really would like to thank all the collaborators here. Of course, our thanks go out to the participating parents and their children. We just heard from Brenda what an impact it has to have a child in the hospital with RSV. So it's actually great that you participate in the research as well. I can think you could have other things on your mind. We would like to thank the Bill Melinda Gates Foundation, and we would like to thank the University Medical Center in Utrecht. And lastly, our thoughts also go out to our colleagues in Afghanistan who are here at the slide as well. We were actually ready to roll out the study there, and then the Taliban came. So thank you so much for your attention, and I'm happy to answer any questions.
Thanks very much, Yvette, for a lovely overview over what's really a comprehensive project held together by many young researchers. So it's lovely to see. Keith has a question.
Thanks so much for an excellent presentation. You know that over the past few years, we at the Gates Foundation have been studying intensively the mortality of RSV in the community, which I think probably wasn't quite reflected in the IHME presentation. But your data are really interesting because this is a high mortality, 5% in hospitalized kids. And you may or may not have seen some recent data which are quite shocking, which are around what fraction of hospitalized kids in poor countries actually get access to oxygen. And I wondered if you have those data from your study.
Yeah, we do collect data on these clinical characteristics. So we collect data on the percentage of children that need oxygen, but also those who have been mechanically ventilated, which is not always available at the intensive care units where we conduct the study. I don't have specific numbers, but we will look into that for the publication.
Yeah, I think if you're looking for risk factors for mortality, that may jump out.
Thank you for the suggestion.
Thank you. The lady with the yellow jumper over there. Oh, she was first. Okay, great.
Hi, I'm Tinshu from University of Edinburgh. Very, very excellent talk, and I can see so much hard work from so many people, including a long list from your acknowledgement slide. I have a question about cause of death. So I'm wondering whether you have looked into the cause of death. So to look at how much is for example, what is the percentage of children who had RSV as the primary cause of death. So the cause, so that means RSV death, the death which were attributable to RSV exposure. And what would be the percentage of death which were associated with RSV, but doesn't mean that RSV was the primary cause of death?
Yeah, that's an interesting question. We don't gather the direct data. If you mean the WHO definition of cause of death, we don't have that. But we asked the collaborators to write down what they think has been the cause of death. And usually, for most deaths here, it was severe respiratory disease, multi-organ failure, and also sepsis. So I hope that does sort of answer your question.
Thank you very much. I do have a follow-up question, if that's fine. Actually, that relates to what Kit mentioned earlier about the... so I have another question about the severity measurement. So you mentioned about the percentage respiratory associated infection which were attributed to RSV positive. I'm wondering whether you also look at other severity measurement, for example, mechanical ventilation. So how much percentage of RSV admitted to hospitals who might require the mechanical ventilation?
Yeah, I don't have that number here, but we do look at that. We do measure that data. And I also have to say, as I just mentioned, that for some hospitals, some children may actually need mechanical ventilation, but the possibility is not there. So the number probably doesn't reflect the real need that we encounter.
Okay, we're going to have to move on, sorry. We have 3 more people who want to ask a quick question, because otherwise you're going to lose your break. Please.
Hi, Natasha Haas of Vanderbilt University. Real quick question, wonderful work. What about co-detection? I'm sorry if I missed it. Are you looking at viral co-detection or bacterial co-detection and antibiotic usage?
Yeah, so in 3 study sites, we also measure influenza. So that's what we measure. We don't measure any other pathogens, unfortunately. Yeah.
Okay, thank you.
Sarah Adams, I'm a pediatrician with Moderna. Thank you. I was just wondering, if I caught your slide correctly, it looks like about 3/4 of your tested subjects were in Nepal. And I was wondering if you could just comment on why that is and how it affects your findings.
I think it's because we have a very enthusiastic team in Nepal. I don't think the disease is necessarily worse over there. And it's because we have 2 hospitals in Nepal who are participating, who are huge university hospitals in the capital city. So they see a lot of patients. So that's the reason we have many cases from Nepal.
Thank you.
Pedro Piedra from Baylor College of Medicine. Very nice work, Yvette. My question is very simple. You talk about the season, and post SARS-CoV-2, the season was very unpredictable. So I wonder, did you all survey the full year or very well-defined time periods?
Yeah, so we thought about this a lot, and we didn't test for the whole year because it would mean that at least half of the year you're testing a lot of children without getting any results. And our main focus was on describing characteristics of those with RSV disease. However, so we used previous reports of respiratory infections in the countries that we are collaborating with. And so, for example, our collaborators in Nigeria started at the same day that they did the year before, but they had to test and test and test, and then 4 weeks later they captured RSV. So there was a shift that we saw. And we also continued until we had 3 weeks of no respiratory or no RSV infection anymore at the study site.
Thank you.
Yeah, thanks.
Heather, last question.
Thank you. Thanks for allowing it. Heather Zoa, South Africa. Thank you also for a very nice study. I wanted to ask if you're capturing PCV coverage across the sites, because we know that PCV immunization actually reduces hospitalization for RSV-associated LRTI because of reduction in co-infections.
Yeah, I believe we do. We ask every mother if she has been vaccinated for either pertussis, tetanus, or influenza. So we have the data, I just haven't showed you.
But this is specific to PCV.
It's in the kids, not in the moms.
Sorry?
In the children, not in the moms.
Oh, sorry.
Pneumococcal conjugate vaccine.
Yeah, we do. We also ask questions for the immunization of the child, so we have that data.
Do you have a sense of the coverage?
I don't know them by heart. No, sorry.
Thank you. Right, I think we'll give you a round of applause.
Thanks.
And with that, we have a 20-minute break, and it would be wonderful if we could all be back by 10 to 4 so that we can continue with the session in a speedy way. Thanks very much to all speakers. and all people who ask questions. Questions?
the seats. Yeah, please take your seats. It does actually start by itself. It was quite good because I was worried it was going to interrupt. Someone stole my cup of tea. That's annoying. Please can everyone... Can you take a seat, please? If this is the only... I don't know. But we can switch spaces. It's also better. It's because you can see better in the middle.
Authoritative and commanding voice. It should stop working now. So I think if everyone can come in and take their seats, then we'll start in 1 minute.
Three men in the next session, but anyhow, we had 2 women, 1 guy, and the one before. Not too bad. The industry symposium by AstraZeneca this morning was 3 men. Already, I didn't go. I thought we were going to hear all this, so much epi data and burden of disease that you can swallow.
So you can really see that this is a post-COVID meeting, and people are enjoying seeing one another after many years. But I think we can start the session. There's a few people still coming in at the back, so you can just come in and take your seats. My name is Cheryl Cohen, and I am an epidemiologist. I work in South Africa at the National Institute for Communicable Diseases. And I'll be chairing the second half of our Burden of Disease session. I think there was a lot of discussion and questions from the audience in the first half, and hopefully the second half will also be very stimulating, and there'll be lots of discussion. And we've got 3 great talks lined up, focusing on I think some of the groups that were highlighted before tea, the young infants as well as the elderly. And then the final talk will really be talking about COVID and RSV, and already before tea a number of talks alluded to the importance of this topic. So without further ado, I'd like to introduce the first speaker of the second half, and that's Paolo Manzoni. And Paolo is known to all of you. He's one of the co-chairs of the meeting, and we're delighted to have him speak. Thanks.
Thank you, Cheryl. Thank you, Beate, for chairing this session and for inviting me to this talk of mine. My task here is to talk to you about the burden of RSV in neonates. Since I'm a neonatologist, I wish I am a good one to tackle this point. This is my disclosure slide. When we think to the burden of RSV in neonates, we need to approach this issue mentioning not only the short term that is clearly known, and we will go through that in a minute, but also mentioning the long-term burden, something that remains partially undisclosed and partially unclear. It's needless to say that the burden of RSV in infancy is extremely high, that RSV is the primary cause of respiratory tract infections in neonates and infants. You all know that immunity is only transient, that infections can be repeated throughout infancy and later on. And you unfortunately know, just like I do, that there is no current treatment and no treatment available nearly in the next future. So prevention is the cornerstone, and prophylaxis mixing pharmacological and not pharmacological measures is the only way to tackle this point. This is data that have been very recently published by Nathalie Mazur, by the group of some researchers in the group of Resvinet led by Johan Wildenbest. And these data show which is the numerical burden of RSV in infancy. because it's a very nice cohort study exploring the incidence of RSV infections, the incidence of hospitalization, and the incidence of intensive care admission in pediatric wards in those who got affected. And we know here that based on these data that have been coming out from 5 European countries, RSV infection in previously healthy and term newborns affects 26% of them in the first year of age, with episodes of bronchiolitis or lower respiratory tract infection affecting 14% of them, leading to hospitalization in less than 2% of cases and leading to PICU admission in 0.1% of cases. So this is the most recent data that can be used when we need to have figures. But besides the figures, there are some other bulleted points that I want to touch with you. RSV is the main cause of mortality and hospitalization medical needs as a whole for respiratory tract infection of the lower airways in the first year of age. It's extremely more frequent and extremely more dangerous than influenza virus. This is something that for not pediatricians is not that automatic to think. Also, RSV leads to hospitalization for pneumonia in very many cases, both because it may cause pneumonia itself and also because it may be associated with other causes of pneumonia like bacteria and so on. Majority of infections occur in otherwise healthy term newborns, and this is exactly the opposite that we could be thinking based on the availability of the only licensed drug for prophylaxis. Palivizumab is reserved to high-risk infants, but in turn, 85–90% of hospitalization occur in babies who wouldn't be eligible for such prophylaxis. And timing is critical because during epidemic season, some 80% of hospitalization occur in the first 2 to 3 months of life, meaning that this period is the most important one to be protected for a number of reasons. These data from the USA show clearly that the peak around 2 months of age is true for not only hospitalizations, but also for PICU admission and also for episodes not leading to hospitalization. In addition, let's remember that the burden of medication use and the burden of use of healthcare resources associated with RSV is extremely high. Some 80% of infants affected by bronchiolitis actually receive antibiotics, actually receive steroids, regardless of the recommendations that usually these recommend or discard any advantage from using these drugs. But as a whole, when a young baby, when an infant in the first 6 months of life has a bronchiolitis by RSV, this translates into a burden of morbidity and a burden of causes to require medical attention or even medications that exceeds way much the burden of the disease itself. Another way to look at the burden of RSV is to see what occurs when a prophylaxis is administered. And this is secondary data from the first randomized clinical trial on nirsevimab 2 years ago. Looking at this data, it was clear that by preventing RSV, we were able to prevent significantly all types of respiratory infections in the first year of age. simply because the burden, the specific role of RSV is such high that by preventing it, there's a considerable advantage in decrease of overall respiratory morbidity. RSV is dangerous for neonates and infants, and this is something that relates with the previous slides in which I showed you the peak of incidence, for a number of reasons. The number one reason is that the maternal antibodies, whenever existing, their levels are waning over the first weeks of life. And this is true independently by the starting level of the antibodies. So the point is that term baby may have an adequate reservoir of antibodies, but those antibodies unavoidably end their activity within the first 2 to 3 months. And if the baby was born preterm, the starting level of antibody was still lower, and therefore the protection will end earlier. The point of having antibodies as soon as the baby is born is extremely important based on the number of studies like the ones that I'm showing you here, where it has been consistently shown that babies who feature RSV severe infections in the first months of life always do have levels of serum antibodies against RSV 2, 3, or even 4-fold lower than those babies who do not feature such an infection. In other words, we know that the more we have, the more we get protected, and the more we have, the less we get hospitalized in the first months of life. So this is clearly advocating for having some strategy enabling infants in the first months of life to get antibodies. In addition, the risk for severe respiratory infections in neonates is even higher when the baby is born preterm. And this is due, just like I was mentioning in my previous talk earlier this morning, to a mix of anatomical and immunological reasons. Lungs of neonates, even more of preterm neonates, are still immature anatomically, and immune system is not yet developed. Therefore, the ability to defend against the viruses or pathogens is impaired in the first weeks of life. But I want to focus on the point of the transfer of antibodies through placenta during pregnancy. In this transfer occurs mainly during the third trimester, with a peak around 32, 35 weeks of gestational age. As a whole, the transfer is linearly proportional to the gestational age, meaning that the full transfer can be there only if a baby is born at term. Whichever the anticipation, whichever the degree of prematurity, there will always be a certain degree, lower or higher, of decrease of maternal antibody. And this is shown clearly by these historical data by Dr. Young from Hong Kong in the Lancet 68, so more than 50 years ago, measuring and showing that even only being born at 35 weeks of gestational age instead of 39, that is the term, implies having 53% less antibodies in the cord blood. And this is an important point. I'm a neonatologist. I don't know how many of you are neonatologists. And the common feeling is that being born at 36, 37 weeks of gestational age is not a disease. I would say correct if you want to reassure the parents and the families, But if you want to look at the physiology and immune competency, this is not the case. These babies are still premature, and their weakness or their weaknesses are there, and this is one of those. In addition, you know very well that the immune system is still developing at birth, and this is one of the reasons I'm very practical, justifying the point that very few vaccines can be administered at birth, as you know. But as a whole, if a baby is premature, this is even stronger as an issue, and implies that once an infection is acquired, clearing this infection is more difficult than if a baby is already 6 or 7 months old. Anatomical issues, in addition, complete the critical picture of these babies because their lungs and their airways are not yet developed. And so we can understand very clearly, if you take a look at these pictures, what does it mean to have a bronchiolitis when airways are still of this category or even those. Keep in mind that the saccular period is still there around 32, 34 weeks of gestational age, so not that far from the birth term. And if a baby happens to have a bronchiolitis when he's 1 month old and he was born at 35, his or her lungs are still like this. And when we measure the functional capacity and anatomical characteristics, you can understand how big is this issue because the lung volume, the number of alveoli, and the diameter of alveoli is extremely lower compared with term, determining that clearing an infection becomes a true issue. In preterm infants, several studies have investigated the specific weight of single risk factors, and this is the ultimate analysis. This study, the PONY-1, listed and identified 7 specific risk factors that apply for an increased risk in preterm infants, in addition to maternal antibody lack of transfer and anatomical issue. And predictors in this other paper of ours of hospitalization in infants affected by comorbidities show that when a comorbidity is there, the risk of hospitalization is higher than when prematurity is the only risk factor. But mortality, in turn, may be affected only by comorbidity in high-income countries, because in low-income countries remains determined mainly by the disease rather than the presence of comorbidities. We presented here a poster in this conference where we reviewed in a systematic way all studies assessing the weight of maternal risk factors related with the occurrence of early RSV infection. And what we found is that for OBGYN, smoking while pregnant and no breastfeeding are the only 2 specific and statistically significant risk factors associated with the maternal management and with the maternal input to the health of the baby. So when these 2 factors are there, RSV infection is more frequent, and so it's no surprise that based on this study from the Italian Society of Neonatology, breastfeeding is able to protect from RSV infection in the first months of life up to 1 year, and determines 57% reduction of the risk, even when breastfeeding is not prolonged longer than 6 months of life. So we have a few tools, but advising mothers not to smoke, of course, and advising mothers to breastfeed at the moment are the only two meaningful and evidence-based tools to prevent disease by the mother. I want to spend the last few minutes about the long-term burden. Here we have experts like Professor Baraldi, who joined us, and like Professor Stein, knowing very well that the long-term burden of RSV implies the occurrence of wheezing, of asthma, and decreasing the quality of life. This is an historical systematic review showing very consistently, and this is also pictorially very understandable, that whenever early RSV infection occurs, some consequences in terms of decreased respiratory functions and or occurrence of wheezing is there. The Regal study explored this association throughout the ages, and we found out that up to 30 years of age, there is evidence linking RSV early infection with respiratory outcomes. And therefore, it's no surprise that the Mackey trial 8 years ago showed very clearly that by preventing infection in the early months of life, it was possible to reduce by 61% the occurrence of wheezing and the number of wheezing days in the first months of life. The follow-up at 6 years of age showed once more that the occurrence of asthma was still significantly and positively affected throughout the years, even though the lung function didn't show significant differences. This is clearly an area where there's an unmet need to explore further, but it's very intriguing because it's possible, and other speakers will expand this area more than I, it's possible that by preventing early RSV, we can actually prevent late respiratory outcomes. Needless to say, and this is my final point, that the quality of life in the years following early infection in neonatal age is affected, not only because of the wheezing that may be repeating year by year, but also because of the use of medication, because of the need for medical assistance, because of the quality of scholarization of these babies that is affected. Take-home messages of this talk, very, very reasonable statements. RSV burden in neonates and infants is substantial, and mortality remains an issue, especially in low and middle income countries in these ages. Please take into account, be aware that the long-term burden of RSV infection, including wheezing and asthma, is probably high and will probably turn into an area where early prevention may confer late advantages in terms of healthcare use and health quality. Since the only preventable strategy now, strategy to decrease this burden is prophylaxis and prevention now, let's focus on enabling as many children as we can to receive prophylaxis based on recommendation, and luckily and hopefully based on the availability of new monoclonals or newer strategies that can reduce the burden for all neonates and not only for high-risk neonates like it used to be for palivizumab. Thank you very much for your attention.
Thanks very much. Are there any questions? Okay, perhaps you can.
I have a question. On one of your slides, it showed, if I saw it correctly, that women if the mothers are less than 25 years of age, there's an increased risk of the babies.
Yes.
Which is quite a surprising observation, and it has implications for RSV in low and middle income countries if this is reproduced, because the age of the mums is usually lower.
Yeah, you are pretty right, and statistics are usually a slippery surface to get interpreted, but this is the data, and in high middle income countries, this is clearly associated with a low socioeconomical level, and with the multiparity of women having begun to give birth to neonates very early in their age. So it's a mix of association. Unfortunately, when we look to statistics, something pops up, and the true significance of these may remain not that clear, but this is the explanation behind that.
Thanks very much. Unfortunately, we don't have time for more questions. I'm sorry, but we'll move on to the next talk, which is moving to the opposite extreme of life and is on the burden of disease in older adults, and it will be given by Edward Walsh from the University of Rochester Medical Center.
Thanks for asking me to speak on this topic. The burden of RSV in older adults, and I could have kept this to one slide and said that it's rather large and probably underestimated. But I will review some of the data, at least specifically with regard to Western areas such as the US. Let's see. That's the button. Most of the time we'll talk about things like incidence. What's the incidence? Oh dear. This is obviously a slide I wasn't prepared for. That is, it moves. We're usually thinking about things of incidence in terms of any RSV infection in this population, outpatient visits with medically attended respiratory disease, hospitalizations, and deaths. But some of the aspects of infection that we should consider about with RSV in older adults would be the functional impact and quality of life that this virus induces in this population, as well as some of the acute cardiovascular events that are associated with the acute infection, such as myocardial infarction. And then longer-term effects in some individuals, lung disease, on their functional status. And then, of course, what does this cost to society? I'm going to need to do that. In looking at the two top tiers, deaths and burden, where we have deaths and hospitalization, where we probably have the largest amount of study data coming from mostly Western and developed countries, I just want to point out that we have a lot of modeling studies that actually began in the 1990s and continue, and we also have prospective illness studies that are done. And I just wanted to point out some of the limitations and assumptions that go into these studies. For instance, for the modeling studies, we have to assume, for instance, that the RSV circulation in infants, which is what's used in many of these modeling studies to link with adult respiratory disease, that this pattern and circulation of RSV in the child, in the infant group, is relevant to the adult group. I want to just mention that there's considerable inaccuracy on administrative databases that use ICD-10 codes and so forth for identifying RSV infections, in large part because not only when the tests are actually done in hospitalized patients, they actually don't even get coded as such. And then it's very complicated math, and I have trouble with that. As far as the prospective illness studies, however, I point out two sort of limitations or things to think about when analyzing these studies, and that is, what are the screening criteria used for who you test? If you use fever as a criteria, you're going to miss a lot of adult disease. It's been well shown that fever is not that common in older adults. And then case capture, meaning the testing methods that are used, and I think we'll get to this and illustrate this in a few minutes. All right. As far as the bottom two tiers on this pyramid, prospective illness studies. These listed a few here. And again, the same limitations, diagnostic methods that are used, the screening criteria, and then we get into things like the generalizability of these studies because they're usually and often single center. The same thing would be true with cohort studies with one added caveat in that there are very few of these that are done. They're difficult, and follow-up is difficult. They're quite expensive. Again, the diagnostic methods used, and then, of course, the single-center generalizability of these. So I just want to go through some of these studies and point these factors out. This goes back quite a bit to one of the very earliest studies by Douglas Fleming in the UK, in which he showed that you could link RSV illness, again, in the pediatric population, with the RSV diagnosis in the youngest population, to ARI and deaths in older adults. And his comment at the end of this paper, I think, was quite predictive of what we would find, is that these analyses suggested that RSV is as important as influenza, and I can be cautious with that statement, in causing morbidity and excess death among elderly adults. But I would want to point out in the latter two graphs on the left how the RSV and influenza peaks don't always coincide, and so it does become an issue when trying to look at some of these modeling studies. Modeling studies from about 20-some-odd years ago on the left, and on the right, a more recent one by Hansen, show the number of deaths, for instance, in the US of approximately 11,000 in adults over age 65. And then 20 years, 30 years later, we find that the numbers are slightly increased, but relatively in the same ballpark. But I think one of the interesting things was the heat map that he showed, and I think this brings out some of the other issues. This is a heat map of the mortality incidence in older adults in the US, and you can see that across the US, they're quite different. And I think this is something that we really don't recognize. And this is a modeling study that was recently published from Yale, and I think it was interesting in the sense that although it showed, as always, there's a socioeconomic status difference in hospitalization rates in children, which we've all known about, it's also true in older adults, where the risk of hospitalization is about double for older adults with lower socioeconomic status compared to those in the upper socioeconomic status. I want to just mention a few things about prospective cohort studies and the information that they provide us. And as I mentioned before, these are expensive, hard to do, they take a lot of time, requires a lot of follow-up and keeping track of large numbers of patients over several years, and so there are very few in the literature to look at. And I show on the left, in blue, a study from Rochester, and on the right, a study from 3 European countries that are relatively recent. And a couple of the points I'd make on this study, or these two studies, is that the incidence of actual RSV infection really was quite similar in both of these studies. You have about 4.75% in a healthy elderly population. You have a 6.5% attack rate in the high-risk elderly population, shown here in the blue on the left, whereas more recently, similar numbers, 4.2 and 7.2% evidence of infection. But one of the points I'd like to make in red at the bottom is that serology was used to identify between 1/3 and 40% of these infections. And so studies that may just rely on PCR are going to be underestimating this disease. And there are several reasons for that we could discuss. I also might point out on this slide, you can see here clearly that although a significant number call their doctor or see their doctor, regardless of whether they are relatively healthy or they have underlying diseases, the group that ends up in the emergency room, the hospital, and dying are those with high-risk conditions. And in this situation, we were talking about congestive failure and COPD. And then looking at medically attended outpatient respiratory infections. I think some of the best studies come, again, from the CDC's influenza vaccine efficacy studies done at Marshfield over a 12-year period, Marshfield, Wisconsin, and then also at Kaiser Permanente in Seattle, Washington, more recently, with a 5-year study. And contrast that to what Marie Zambon showed about 20 years ago, and that between 15% to 11% of infections seen in the office for medically attended disease is caused by RSV. And I also might point out in the middle box there that the incidence rate in patients with COPD was about double that in patients without COPD. And again, emphasizing the importance of underlying risk factors in identifying the incident rate of RSV infection in this population. And then I just want to use this slide to illustrate a point. The police officer here is talking to the man who's crawling around on the ground, and he says, "This is where you lost your wallet?" And he says, "No, I lost it in the park, but this is where the light is." And this is, in a certain sense, some of the concepts that you might think about in when do you test patients. And this is, on the left-hand side, is a short study that we did over a 1-year period in Rochester, looking at RSV in adult populations, and you can see that you've got the RSV season somewhat separated in the upper panel. You've got influenza occurring a bit later then, but still overlapping part of the RSV season. In the lower panel, what we looked at in the dark bars is the number of respiratory illnesses, all respiratory illnesses admitted to the hospital over this period of time. The gray bars at the bottom, though, are showing how many tests were done for respiratory infections. And what you can see clearly is that during the RSV season, there was no real bump up in number of tests that were done. But once flu hit, that's when people start testing. And so in this particular instance, if you were doing a study and you were using when does influenza occur, or using an ILI-specific rate, or incidence of ILI findings with fever and so forth, you would have missed a lot of the RSV infections. I just want to point that out. And then there's some recent data. This is from Angela Branch in Rochester. This is a 3-year study using 3 centers in New York, Rochester and Columbia University in New York City. Somewhat disparate populations, but you can see there's about 1,000 RSV hospitalizations over the 3-year period, about 15% in the ICU, about 6 to 9% ventilated, 4 to 7% mortality, and about 15% were discharged to higher care. The age-related incidence, though, and I think the most striking aspect here is that, again, if you just look at 60 and over, you'll get a certain age-related incidence, but you really have to look very hard at the older age group. So it's much like children. You could look at the overall rate in children under, say, age 2, but when you start to dig down and look at the age brackets, you can see it markedly goes up as you go from 65 up to 85 and plus. In the same study, we looked at the risk factors. Most of the studies in hospitalization show that the predominance of patients who are hospitalized have risk factors. And I think I like the Dr. Manzoni's slide where he showed the reverse in the children. That is, 75% of the children hospitalized have no underlying risk factors. We have the exact opposite situation. So we have 75% to 80%, or even higher in some instances, with significant risk factors. And those would include not just age, but in this slide showing COPD, and this is 2 studies. This is the one that I just described in Rochester and Columbia, but also the data from Prasad from New Zealand, in which they showed, and that's over here on the left-hand side of the panel, they showed, and we found the same thing, that in the presence of COPD or congestive heart failure or coronary artery disease, the relative incidence per 100,000 was significantly higher. And so this is one of the reasons why maybe some of these studies aren't so generalizable. This is the COPD prevalence in the US by county. And I thought it was interesting. I'm not sure how to use the marker here. or the, which one will I press? No, no, no. Let's see. No, that's it. Okay. So here are where most of the studies are, or many of the studies are done. Seattle, Washington, Rochester, New York City, Nashville, Tennessee, Marshfield Clinic up here. But look at the incidence of COPD in the US. It's almost like our histoplasmosis belt, which is rather curious. But clearly, if you were to then look at risk factors, you have to start thinking about your own geographic area when trying to generalize some of the data on a national basis. And so I think this was a very nice paper. It was recently published by McLaughlin in OFID. And these are some numbers that you could put up. These are approximations. They're based on a lot of the data that I showed, plus many other studies, trying to put them all together and come up with some sort of estimates of incidence. And like I pointed out, some of the things you want to think about, the timing of the studies that you do, the case definitions you use to select cases to test, what are the optimal tests besides just PCR? Should we be looking at serology? And I might refer you to some posters that are outside looking at things like saliva, as an example, for better diagnostic testing. And then the generalizability of these studies. And before I finish, I'll just finish with really a paucity of data on functional status and quality of life following RSV in this adult population. And what I show here is in the upper panel and the lower panel, 2 functional scores that we looked at in Rochester after 2, 4, and 6 months after discharge with RSV infection. And what this illustrates is that in those people who are relatively independent, whoops, let's see, here we go. Relatively independent, living at home, they really don't have much of a change in their functional status, their cognitive ability, their ability to live alone. But if you start to look at people who are already living with some assistance, either with family or caregivers who might come into the home, you do start to see persistent long-term effects following the RSV hospitalization and discharge. And if you look at skilled nursing facility, you see it in all of the functions that we measured over the next 6 months. And this is a slide of data from Mayo showing that, and this is a small study, but again, looking at quality of life issues following RSV infection. And in the dark green is influenza, and in contrast then in light green is RSV. And it shows that after about 2 weeks in relatively healthy individuals who are seen in an outpatient setting, they pretty much return close to normal. So the big issue is, what's going to be the impact of vaccines? And the question could be raised, well, which groups within the population, what age brackets are going to do best with vaccines? Will we affect hospitalization? Will we affect deaths? And, you know, we need to be able to assess the overall benefit in these various groups. And just to leave you with this thought, we're all getting older, and there's more of us. So when I started working with RSV, I wasn't in this group. That was 40 years ago. Unfortunately, now I'm in those high-risk groups. So I guess I'm thankful that we're starting to come up with vaccines for this. But I think both in the US, we're going to see continuing numbers of older people, and over the next 20 and 30 years, if a vaccine is going to be effective, it's going to be affecting far more people than it will today. And it's not just limited, obviously, to the US. In Europe, it's growing as well. And I want to point out, very nicely, I thought this was appropriate, that we're here in Lisbon. You can see it in the map of Europe. And they have one of the highest incidence rates of older people. So I think it's appropriate that you held it here for this talk. Thank you. Take any questions.
Thanks very much. Ruth has a question for you.
I do. Thanks, Ed. That was a great talk. I'm wondering what, if anything, we know about the burden of RSV disease in elderly people in LMICs, and indeed what constitutes elderly in LMICs, which may be different than our high-income country definitions.
Yeah, I think we've got very sparse data and very, I would say probably highly inaccurate data. There's a lot of issues in low and middle income countries that are clearly different. Testing, obviously very, very different. The proportion of people in those countries who are older compared to younger is very different. You know, if you look at the US population, Western Europe, the populations, it's really a sort of a straight up and down numbers now, whereas in these lower middle income countries, you've got really not that many older people. And so you've got issues that you have to think about.
Yeah, but just one other comment about that. I think COVID taught us this, that our definitions of elderly have to be flexible. For example, in India, 50 might be considered elderly, whereas
well,
not.
That's a good point. And so if you're 50 and you have COPD, that's an important issue. If you're 50 and have heart failure, that is a very important issue. And I didn't show those data because I was limited to 60 and up for this talk. But you're absolutely right.
Thanks. We have another question.
Thanks. Great talk. Laura Hammett from Johns Hopkins. I'm going to take you up on your invitation to discuss why PCR doesn't detect RSV infection in older adults and the higher detection that you're seeing with serology. And what, if anything, should be done about that to either improve diagnostic methods or to encourage use of serology in our surveillance studies.
Yeah. Well, I think the issue about picking it up with PCR, which I think is the best tool we have if you're going to pick a single tool to look at. Well, I wouldn't say that completely, but it's the nicest and easiest to use. Adults shed about 1,000-fold to even much less virus than do younger infants. Now, we know PCR is quite sensitive. However, I think that is an issue. The second issue, I think, is that often when patients present to the hospital or to an office with RSV, they're presenting late in their course of their illness, generally around day 6 or 7 or sometimes even later. And serology may pick those up, whereas PCR will not. And how will we address that? I don't know. Serology is great for cohort studies, clearly. It's a little less, and in fact, it would be less effective as a diagnostic tool, even in a research study, to get acute blood and convalescent blood, because we've shown, for instance, that the anamnestic response is very quick. Within 3 to 4 days, you're starting to make increasing amounts of antibody, and so you may lose some sensitivity. And I can only say that you just have to do both if you want to get accurate information.
Thanks. Thanks very much. I think we'll move on to the final talk of the session, and that's on COVID-19 impact and the burden of RSV disease, and it will be given by Dan Weinberger from Yale School of Public Health.
Okay, thanks for having me. I feel like I've given some version of this talk like 5 times over the last year, so hopefully this is something fresh. I've tried to put a different spin on it this time, but yeah, so, okay, the slides are, okay, these are my disclosures. So, you know, I think there's still a lot of important questions about what's happened over the last couple of years that we're trying to understand. So I first want to start by just trying to review what's happened in terms of the dynamics of disease, some of the shifts in the age distribution and severity that have been seen. We'll talk about some of the modeling work that's been done by our group and others to try to understand some of this work. And we'll talk a little bit about the question that was raised in the industry symposium this morning about you know, when things will return to normal or if they've already returned to normal in some places. So these are some data from the WHO FluMart website, and you know, the absolute numbers here aren't super important because you know, diagnostics have changed over time, but it lets us see just sort of how the dynamics have changed. So this is data from Argentina. where we can see, the very obvious disruption, during the early part of the pandemic, followed by a couple of subsequent waves, and sort of the most recent data shows that it's come down. And Deus, who's shown on the bottom, has been sort of pulling together some of these data. The patterns vary quite a bit between different countries. Australia had, I think, one of the earliest and most severe sort of waves after the initial disruptions, an out-of-season epidemic that occurred, followed by, potentially a return to closer to normal seasonal timing. And then, we can see in Germany, they, again, had sort of a couple waves after the pandemic, but, there's a lot of variability that we've seen. And if you look, in the Netherlands, which, right next to Germany, the dynamics look completely different. So we have these sort of distinct epidemic waves in Germany, whereas in the Netherlands, there was sort of this initial wave, but then it just sort of simmered at a low level for quite a while, which we'll talk some more about. Zooming in on South Africa, I think that's sort of one of the first places where we saw a hint of what was happening. The typical seasonality is shown in red here. That's the last pre-pandemic year. There was this shift to an out-of-season pandemic in 2020. And then in the most recent year, there was sort of a return to normal seasonal variation, although Cheryl's sitting up here, so she can correct me if this is incorrect, but it seems like it's returning towards a normal seasonal timing and intensity. The pattern that we saw in the US was really unusual, and I think is raising a lot of questions about what drives the timing of RSV epidemics. So in the US, we have this really distinctive seasonal pattern where the epidemics almost look like it's a traveling wave across the country, where you have early epidemics that happen in Florida and Georgia in the southeastern part of the country, sort of down here, and then it sort of spreads outwards. And in the initial post-COVID wave that we had in the US, we again saw the first RSV activity happening down in Florida, out to Georgia, and then basically it followed the exact same pattern that it usually does, but it happened 6 months out of season. So this was happening starting in March and April instead of starting in September, October or so. But this is basically showing that the lag between the states in terms of when the epidemics were progressing through the states was happening at a similar time. So it's really raised a lot of questions about what drives this. In the Netherlands, Louis' group, led by Yvette, has been sort of looking at these patterns of out-of-season epidemics with the spread study. And the dynamics there have been quite interesting, where there was this initial wave in the summer of 2021 after that lockdowns ended, and then this sort of endemic transmission that persisted for quite a while. There was a bit of an up and down that occurred, and it really didn't fully go away until last summer, when the school holidays started, and then there was a subsequent resurgence in the fall, close to the regular seasonal timing that was seen there. What was also shown in the Netherlands and has been shown in a number of other settings as well, is the shift in the age distribution, where we were seeing in this initial wave an increase in older kids coming in to the hospital with RSV. So you can see the median age of hospitalization during sort of the pre-pandemic period over here, and then we see a shift towards an older average age of hospitalization in this population. Similar pattern was shown in this recent paper from Denmark, where there was a clear increase in the risk of hospitalization across different age groups. Of course, the neonates are have the highest baseline incidence, and they suffered a lot during that first wave. But you also see increases in hospitalizations out in these older age groups as well, where you typically don't see much burden at all. What's interesting, though, is that among the children who did get hospitalized, the severity, as measured by sort of risk of ventilation, was similar in the pre- and post-COVID period. So we had more kids coming in, more kids getting infected, more kids getting hospitalized. But among those kids who did get hospitalized, the severity was sort of similar to what was seen during previous periods. These unusual dynamics have sort of also allowed us to sort of probe a little bit more sort of the contribution of RSV to disease burden in general. In the previous talk, we were talking about sort of the difficulties of teasing out, the contribution of RSV from flu and, other things that are happening around the same time. And as Ron Dagan likes to say, we had this beautiful natural experiment that was caused by God during COVID because all the viruses went away and then they came back sort of one by one. So we had, flu and RSV and human metapneumovirus all coming back at different times, so we can look to see how the patterns of other outcomes changed as the viruses came back. So we were able to develop statistical models to try to quantify those variations in CAP and in other LRTIs and pneumococcal pneumonia. We see a huge contribution of RSV to alveolar pneumonia. Maybe half of the CAP cases, 20% of other LRTIs, and maybe 15 to 20% of pneumococcal pneumonia cases. And we've done some validation sort of looking forward, and this, so Ron can feed us the viral data, and we can basically tell him sort of what the incidence of CAP will be or other LRTIs, so we can show that this has some validity as well. To really understand sort of what's driving the dynamics, though, you have to use a mechanistic model, and a number of folks in the room here have sort of used approaches like this, where you basically try to break down the population into different compartments based on your immunological status, so whether you have maternal immunity, whether you've getting your first infection or subsequent infections, and whether you're progressing to hospitalization and death. And sort of how those things change, as you progress through different age groups. So we can use these types of models that are developed with data from the pre-pandemic period to evaluate how changes in things like contact patterns and sort of waning of immunity over time might influence disease rates. So Ginny Pitzer from Yale and Gigi, who's now with Moderna, developed these models and have given us some insights into what's happened. So there are a few sort of buckets of things we've been able to learn from these types of approaches. So we think that the patterns of the initial reemergence that we saw were driven by a combination of factors, including sort of the stringency and duration of the initial lockdowns and sort of how long that sort of kept RSV suppressed, how much external seeding there was, so how frequently does RSV get introduced into the community, and there's also probably a role for sort of climate and seasonal variations and the intensity of seasonality of RSV. And in addition to our work by Stefan's group and the Koltai paper here, and Rachel Baker sort of, I think, hit on similar topics. I think that many of these models also sort of can capture and maybe had predicted some of the age distribution shifts that we've seen, largely due to the fact that we had this large cohort of children who are susceptible to RSV and who had either never seen RSV previously or who hadn't seen it recently and who might have had sort of some waning immunity that contributed to the patterns that we've seen. And Gigi was working with Louis' group as well to try to understand these patterns of sort of endemic transmission of RSV. And it seems that you really need to sort of invoke this sort of waning immunity of RSV to be able to, in some of the older age groups and older children, to be able to capture and explain those longer term dynamics. So, I know this question's been coming up a lot in terms of, when are things going to return to normal, if they are returning to normal. So Deus Thendwa has been doing some work just trying to quantify onset timing of RSV epidemics in different locations. So he did this using that the WHO data that I was showing earlier for a number of different countries around the world, looking at the timing in the pre-COVID period and the post-COVID period. So that's what we're comparing on these plots here. So if things line up along the red line here, that means that the pre-COVID and post-COVID period looks similar. So you can see this is for 2021 in a handful of southern hemisphere countries. you can see that things are a little bit off kilter. The timing was not totally consistent, whereas as we move to 2022, things start to line up more closely, and we see a similar plot for the Northern Hemisphere as well. So things are clearly starting to shift back towards a normal seasonal pattern. I think in a lot of places, the most recent season was a bit earlier than usual, and the intensity might have been different, but we're getting close towards a sort of typical pre-COVID pattern. And several different modeling studies sort of predict that we will return to sort of normal dynamics soon, if we haven't already. Rachel Baker's study down here suggests that it might vary between locations in terms of how quickly you get back to normal, and it might depend on how much variability there is year to year in terms of seasonal variations and so forth. So even across the U.S. where we have different climate zones, some tropical areas it might take longer to get back to normal seasonal patterns than in temperate areas. But overall, I think the consensus is that we're expecting things will be back to normal soon. But I also made a similar statement around this time last year, so take it with a grain of salt. And I'll just end by putting in a plug for this tool that we've been developing, which I think we're going to have to coordinate with the Resvinet folks, because I think they're maybe doing something similar, it sounds like. But we've been just trying to pull together different data sources that are in the public domain to make them easier to explore the sort of current dynamics. So this is just sort of at the hemisphere level. You can sort of zoom in to specific countries, and there are different ways to look at the data. And you can also sort of look at some of our work, sort of looking at changes in the dynamics of RSV as well. Yeah, you can visit the website. We welcome any feedback. It's definitely, the website went up as of yesterday, so we're still working out bugs and stuff, and welcome any comments. So just to wrap up, COVID really profoundly disrupted the dynamics that we've seen for RSV. This has given us some opportunities to learn about the burden of RSV and its effect on sort of related pathogens like pneumococcus. The reemergence of RSV is not going to be governed by a single factor. There are a lot of different contributing factors, and I think that's contributing to a lot of the heterogeneity that we've seen even between neighboring countries. But we are expecting that the dynamics will return to normal or remain normal in the coming years. I'd just like to thank the folks who we've worked with on this and our funders. Thank you.
Thanks very much. Are there any questions for Dan? You did such a good job with time. There's a hand. If you'd like to ask a question, you should come up and go to the mic. Sorry, let's just give her a moment to come forward. You can go ahead.
Hi, thanks. I'll make my question short. Maria Sundrum, Marshfield Clinic Research Institute. This is a really great thing to see. Thank you so much for sharing. I'm curious to know if you and your group have any thoughts about how vaccination for various respiratory pathogens might affect the dynamics of other respiratory pathogens.
Yeah, that's a great. So how the vaccination for other pathogens influences RSV. I mean, I think that gets to sort of the questions about viral interference and sort of whether, the dynamics of flu and COVID might be influencing what we're seeing with RSV. I know there's a lot of great lab data, showing, demonstrating the phenomenon of viral interference. I'm not totally convinced yet at the population level of its importance. I think it's a hard thing to demonstrate and certainly might be a contributing factor, but I'm not sure that it's the main driver.
Is it then the idea that it's kind of like NPIs, not vaccines, are kind of instituting this like relationship between, for example, SARS-CoV-2 circulation and the lack of RSV circulation? Kind of
Yeah. Yeah, I haven't been convinced yet that sort of the COVID dynamic or the SARS-CoV-2 dynamics are influencing RSV. It could be, but I just haven't been convinced by it yet.
Thank you.
Thanks. I think we have one last question, Dan, and then we'll...
Hi, Dan. Thank you for the very nice presentation. I'm Thao from P95. I have a question regarding the modeling approach that you presented, where you use the compartmental model to understand the dynamics of the disease. So my question is, what do you think the most advantage of this approach compared to other approaches, like for example, regression or Bayesian analysis? And how is it difficult to fit that model to the data that you have?
Yeah, so these types of dynamic models are really important, especially in situations like this where you have like really hard to predict nonlinear dynamics. And it's, regression is great for describing patterns, but it can't allow you to sort of ask mechanistic questions. Like with this type of approach, you can, basically try to capture the natural history of infections and modify some of the parameters to see how it affects your predictions and so forth. So I think they're sort of, I think they can be complementary. Regression approaches can help you describe the patterns that are out there, and then, these types of models are often described as mechanistic models because they let you sort of tease apart, the contributions of specific factors in a way that regression can't.
And can the team actually see the seasonal term in the kind of compartmental modeling, or is that it's really difficult to be able to see those things in those approaches?
In terms of the model fitting, or?
Yeah.
Yeah, we usually use like a maximum likelihood fitting, just like you would for a regression type of approach. There's challenges to it. Gigi and Ginny are the experts in this and can probably give you more detail on the sort of nitty-gritty aspects of it. But.
Okay, thank you so much.
Yeah.
Thanks very much. I think we'll end that. Thanks. I'd just like to thank all of our speakers. I think they've really set the scene for what will follow over the next few days in terms of the huge importance of RSV. And I was thinking perhaps even next year, certainly in the next year or two, we'll start to see in the burden session really more about impact and how burden is changing as a result of interventions. And I'm sure that will be a very exciting time. So thanks to the speakers and thanks to the audience for interacting so well. And I think we'll move straight on to the next session, which is the Young Researchers Tournament.
So I'd like to welcome everyone to the future of RSV, which is the Young Investigators Tournament. I'm really thrilled to say that we had many wonderful submissions from young investigators, and we have 4 abstracts to be presented this afternoon. At the end of this session and until Thursday night, you'll have an opportunity to vote on the best abstract. I don't encourage you to vote often, but please do vote early. Votes will conclude on Thursday night, and then we'll announce the winner on Friday. So without further ado, I'm going to introduce our first speaker. This is Jessica McClintock from Rutgers University in the United States, and the title of her talk is Postmortem Nasopharyngeal Microbiome Analysis of Zambian Infants with and Without Respiratory Syncytial Virus Disease, a Nested Case Control Study. Jessica.
Thank you. Good afternoon. So as was said, my name is Jessica McClintock, and I'm an informatics specialist at Rutgers Medical School in New Jersey. Today, I'm excited to share with you the results of our nasopharyngeal microbiome RSV study. As most of you know, RSV is the most common cause of bronchiolitis and lower respiratory tract infections in children in the first year of life, disproportionately affecting children in low and middle income countries, as shown here on this map. Previous studies have shown that nasopharyngeal microbiome of infants with RSV infections have specific characteristics that correlate to the severity of disease, including a lower biodiversity, perturbations of the microbiota, and differences in relative abundance. These studies have focused on infants seen in the clinic or hospital setting, predominantly in higher income countries. We therefore wondered if similar correlations would be found at an extreme end of severity of disease, namely death, in a community setting in lower income countries. Our team previously collected nasopharyngeal samples as part of the Z-Prime study in Lusaka, Zambia. In this study, each decedent underwent one-time post-mortem nasopharyngeal sampling, and these samples were each tested for RSV, and we randomly selected 50 RSV-positive samples, decedents, and matched them by season of death and age of death to 50 RSV-negative decedents. This provided a group of 100 infants between the ages of 4 days and 6 months old. From these samples, we amplified and sequenced the 16S ribosomal DNA to identify the microbes present in the nasopharyngeal space. For statistical analyses, we filtered out any genera with an average of relative abundance less than 0.1%, and for our visualizations, we filtered to 1% level. We used our statistical packages, including Nanomolecules, PhyloSeq, and Tidyverse to complete our analysis. Our first step to address whether changes in the microbiome are present between RSV positive and RSV negative decedents was to observe the overall abundance of the microbes. Here we have a stacked bar plot of the relative abundance. Each sample is a column on the x-axis, and each microbe is represented by a different color to show the overall makeup of the microbes in each given sample. I want to draw your attention to the trend that we see represented by the line, where the microbes below the line represent the 4 most abundant microbes in the RSV positive samples, which are Streptococcus, Haemophilus, Moraxella, and Klebsiella. You'll notice that the columns on the x-axis are ordered based on the abundance of these 4 microbes. In contrast to the RSV positive samples, RSV negative samples have the highest abundance of Streptococcus, Staphylococcus, Escherichia, and Klebsiella. This different trend indicates that there are differences between the two groups and is an encouraging sign that we can see microbial differences in RSV. To better elucidate what these differences are, we look at differences in diversity. Compared diversity metrics is a common step in microbiome analyses. There are 2 main types of diversity, alpha diversity and beta diversity. Alpha diversity looks at the composition of individual samples and includes how many different genera are present and how even the abundance of the genera are in comparison to each other. In our 2 sample microbiomes here, both have 7 types of fruit present with similar proportions of the fruit. No one fruit dominates either microbiome, and therefore we would say that these 2 microbiomes have the same alpha diversity. However, it's very clear to us that the microbiomes are composed of different fruit. This difference can be seen in beta diversity, which looks at the differences between 2 different microbiomes. And it includes which microbes are present and how much of each microbe is available. So when we compare the 2 microbiomes here as a sample, we can see that microbiome 1 has 3 bananas and no watermelons, whereas microbiome 2 has watermelons and no bananas. We also see that there's a difference in the number of apples and oranges present. This can be seen through a beta analysis, although it is not seen in an alpha analysis. It's common in microbiome analyses to have similar alpha diversities, but to have very different beta diversities. But it's still important to look at the alpha diversity. So in our work, we first do look at the alpha diversity. And we use 3 different metrics to represent the alpha diversity and found no significant difference in any of these. This indicates that the richness and evenness of the microbes is similar within all the samples. However, this doesn't directly evaluate differences in diversity between the RSV positive and RSV negative samples. Therefore, we turn to beta diversity to do this type of comparison. We computed a Bray-Curtis dissimilarity index and visualized these results using a non-metric multidimensional scaling, or NMDS, and principal coordinate analysis, or PCOA. In these visualizations, clusters of samples indicate that they have similar diversities to each other. We see in the MDS plot in plot A, a cluster of RSV positive samples in the bottom left. In the bottom left. We also see distinct clustering of the PCOA samples of RSV positive samples to the bottom right-hand corner. In order to determine if this is a statistically significant clustering, we used permutational multivariate analysis of variance, or PANOVA test, and found that this was in fact statistically significant with a p of less than 0.001. This indicates that the diversity of each RSV positive sample is more similar to the diversity of the other RSV positive samples rather than to the diversity of the RSV negative samples. We'd already have established that this isn't due to alpha diversity, and we can see from the earlier relative abundance plot that the microbes that are present are similar between the 2 different groups. Therefore, we are hoping that the differences that we see in these diversity come from the number of total microbes present. And we are able to do this type of analysis through a non-parametric Wilcoxon-Rank sum test, where we compare the difference in relative abundance of each microbe between the RSV positive and RSV negative group. This resulted in 3 genera being statistically significantly different in abundance. Namely, we have Gemella, Moraxella, and Staphylococcus that are different. These genera are shown here as box plots to indicate the different abundances between the group. We see that Gemella and Staphylococcus have lower abundances in the RSV positive samples, and Moraxella has a higher abundance in the RSV positive samples when compared with the RSV negative samples. Previous studies have also shown that infants with RSV have deceased abundances in Gemella and Staphylococcus and an increase in Moraxella abundance. In fact, today our team has a poster here that also shows a correlation between RSV and Moraxella. Our study supports these findings as well as the findings of many other researchers. However, our study is limited in the fact that this is a cross-sectional study, and that our results may be confounded by antibiotic exposure since we don't have any indication of if these infants were exposed to antibiotics. Our study does add to the body of knowledge of RSV since very few studies look at RSV in infants at this extreme end of the severity of disease and in the community. In conclusion, this all points to the fact that we do indeed see differences in the microbiome at this extreme end of the severity of RSV disease in a community rather than a hospital or clinical setting. Gemella, Moraxella, and Staphylococcus are all differently abundant between our groups. This naturally leads us to wonder if the change in microbial presence precedes RSV infection or is an effect of the infection. We believe that microbiome is different prior to infection, and this could be further studied in a longitudinal study where we follow infants from birth through infection of RSV and hopefully recovery. Being able to identify infants who are at a higher susceptibility of RSV would allow medical teams to better treat and better prepare these infants to reduce the severity of disease. I'd like to thank and acknowledge the Bill and Melinda Gates Foundation as well as NIH for funding this research, as well as my mentors, Dr. Gill and Dr. Johnson, for their support in this research. Thank you for your time, and are there any questions?
Thank you very much, Jessica. Open for questions.
Thanks, that was a really nice presentation. I was just wondering if you could talk about the causes of death in the control groups. Are they kids with other respiratory infections or kids that died of accident? Or?
Yeah, most of the infants in the study died of respiratory causes, although exact causes aren't always known. We had a medical team who reviewed the medical charts to elucidate the differences between the groups.
Hi, I'm Radagan from Israel. I have two questions. The first one is just because of stupidity. I don't know enough about microbiome, but does it matter that you have a post-mortem microbiome and how long after the child died you look at it? Because things occur in a child biology. So that's the first question.
Yeah, so we do see a lot of differences. Because it's post-mortem, there are certain bacteria that might flourish more because they flourish in these types of environments. However, the results that we see are consistent with the results that were found in studies done with infants with active infections who are living. We did see a few differences, like other studies show that Haemophilus also is different between the groups. We did not find that statistically significant in our group, and that might be because we were looking at a post-mortem cohort.
And the second question, you mentioned correctly that they may have got antibiotics. You probably know which antibiotics usually are given, and you probably took some normal cultures, and so you can look at a little bit at the antibiogram of bacteria like Haemophilus and others, to see whether they're more likely to be resistant to the antibiotics that they are given. Like Streptococcus, usually pneumococcus responds much better to antibiotic, let's say, than Haemophilus or whatever.
Yes. We just don't have information from the medical records about if they had antibiotic exposure. So thank you.
Thanks. Tony, I think this will be the last question just because of time. Please.
Okay. Pedro Piedra from Baylor College of Medicine. Very nice presentation. As you stated, I was expecting to see Haemophilus influenza. And you kind of stated why might not have been the case. But do you have any further insight into why that did not seem to be the prominent one?
Yeah, so Haemophilus was actually the very next prominent one that we saw, and it was just barely not statistically significant. So unfortunately, I don't have much more to add to it from what I've already said, but we do wonder if it's due to the fact that it's a post-mortem cohort, if we just see that bacteria not as present as we would in living infants. So
nice.
Thank you.
Thank you. Our next speaker is Sascha Spijler from University of Utrecht in the Netherlands. Functional RSV antibody interactions using cells from human epithelium.
Okay, so hello everyone. My name is Sascha. I'm a PhD student from the lab of Jeffrey Beekman from the UMCU. And I'm excited today to tell you about our project entitled Functional RSV Antibody Interactions using cells from human epithelium. So these are our disclosures. And having said that, I'd like to actually start with the end of this acronym, so cells from human airway epithelium, and then specifically on how to model them in vitro, so in proper preclinical studies. We've heard a lot of interesting clinical data, but let me try to guide you through it. So when it comes to modeling the human airway epithelium, there are two main elements that need to be kept in mind. So first of all, which cells are we using and where are they derived of? And here I think we all together made massive steps in the last decade, where we are using more and more human airway systems derived from different anatomical regions, replacing immortalized conventional cell lines, such as Hep2 and Vero cells, more and more at present day, which is, I think, a very positive trend. The second element that we need to keep in mind when modeling the human airway epithelium is how do you actually grow your cells? Or even more specifically, how do we differentiate them from basal precursor cell to all the different cell types that are present in the in vivo situation, so ciliated cells, mucus-producing cells, etc. And here, I think probably most of you are familiar with the air-liquid interface model, or ALI cultures. They really serve as golden standard and have been super useful for many airway-related discoveries, also in context of RSV. Due to the direct contact between the cells and the air, the differentiation process is really sped up. So this is super useful. Yet, I think there are quite some challenges that come with them that we need to recognize. And the first of them is really its low throughput character. They are not easy to handle, resulting in a high workload, and also quite expensive as well. So thinking about these challenges really helps, I think, in thinking also about what it is that you actually need from a human airway model system. And if we think together about what it is that we need, I think first of all, you'll agree with me that we need to mimic the actual biological situation. So it needs to be biologically relevant, especially in the case of RSV infection. Additionally, we would love to have an increase in throughput, resulting in lower costs, higher workability, and of course, the system needs to be reproducible. And this is, I think, where our study comes in. So basically, we've been working on developing a novel model, or improving a novel model, which consists of a novel differentiation method, submerged. So basically, what we do is we collect primary cells from a nasal brush, isolate the human nasal epithelial cells, or HNECs, and those we can expand as basal cells, and after that, we can actually differentiate them in conventional 96 or 384 well plates that are conventional plastic plates, and differentiate them into all the cells that need to be there under submerged conditions. So basically, after roughly 3 weeks, we do see, for example, that ciliated cells are present that are fully functional. And additionally, I think an important part is, for example, when we compare bulk RNA sequencing of basal cells on the left, submerged differentiated cells in the middle, and ALI differentiated cells on the right, we see that those both differentiation methods result in very similar characteristics of our cells, where basal cells are quickly replaced by ciliated cells on the top and goblet cells in the middle. So this really underlines the suitability of our model concerning airway cell differentiation in vitro. And I think this is also a model system that we could use super effectively for studying RSV. So if you think about this increase in throughput, it could really aid in, for example, comparison of strains, because we have this high throughput model system. We could compare strains. We could compare different types of compounds or medications. And lastly, as it's a human primary airway cell system, we could also compare different patient-derived lines. So basically, we started with setting up the model and just seeing if it works, if we can do it. And we also spent quite some time on just comparing different types of readouts. So basically, when starting, the pipeline is quite straightforward, actually. We have our cells, 96 well plate format. We can infect cells apically via the supernatant, after which we can do different types of readouts different days later. So basically, we started using an MK8 RSV-A2 strain, which allows for live imaging, for example, due to its fluorescent character. So one of the first things we did was just looking at our cells, and indeed, for example, 3 days post-infection, upon an increase of MOI, so the more virus you add, the more fluorescent signal we get, which can be quantified as well. And additionally, as qPCR is often used as golden standard as well to characterize mRNA levels, we also did this in our cells, and indeed, again, upon an increase of MOE on the x-axis, you can clearly see an increase in RSV mRNA levels as well. So basically, the system worked. But I think we were not there yet, because I think you will agree with me that a fluorescent lab strain is not ideal. That's not what we would want to do in the future. We would rather look at, for example, clinical isolates that are not necessarily fluorescent. And additionally, I think, for example, if you think about our qPCR, this is quite a low throughput method, whilst we now have a system that actually allows for an increase in throughput. So here we were thinking, what can we do? And we investigated mainly 2 methods. So first of all, we were eager on characterizing whether an indirect ELISA would be suitable. An indirect ELISA is quite a straightforward assay that allows you to characterize both intra- and extracellular F protein in our case. And it's very quantitative. Due to a substrate-based reaction, you get one value out of it that says something about how much virus is present in your cells. So super straightforward. We started comparing several elements. So first of all, here you can compare 2 different days post-infection. If we first look at the black dot, it's 7 dpi, and you can actually see that it's quite saturated, right? All the dots are on the top. At 5 days post-infection, you start to see a little bit of an S-curve, but still the assay was quite saturated. But 3 days after infection, we could actually see a very nice S-shaped curve, which allows you to characterize RSV infectivity. We additionally compared the suitability of our model to characterize the efficacy of, in this case, palivizumab, so an antibody that binds pre and post-F. Here on the x-axis, you can see an increase of the antibody, and that clearly results in a decrease of OD450, so what we measure in the ELISA, which allows you, for example, to calculate an IC50, allowing, for example, later comparisons between different types of compounds. We were also interested in, at first, comparing at least 2 different strains, or at least an A and a B strain. So basically, so far, we had been using the MCAT conjugated strain, but interestingly, when infecting our cells, the B strain, which was actually a clinical isolate, infected our cells in a similar manner. And lastly, we also wanted to compare how our HNEC cells, human nasal epithelial cells, aligned with conventional cells, such as HEP2 and Vero cells. And interestingly, HNECs are in blue. You can see that it's actually a lot lower than conventional immortalized cell lines, which is not necessarily at all a bad thing. It's just what it is. And I think it's actually quite interesting if you think about, for example, which receptors are expressed by which cell types and how that would influence the compound that you, for example, want to characterize. So, having said that, we were quite happy with the ELISA. It's high throughput, protein level, super easy to do. But I think you also have to be realistic, and you get 1 OD450 value out of it. So you lose also a lot of information. So here we were also eager to try out some microscopy-based readouts, which we wanted to do both in a high throughput manner. So we even grew and differentiated our cells in a 384 well plate, and in a high content manner, which means you get a lot of information out of a single well. So basically what we did was we imaged a whole well at a time. It's quite a high resolution. So here you can see, for example, in green RSV and orange ciliated cells, beta-tubulin 4. And the tropism that has already been described before in literature, being that ciliated cells are mainly infected during RSV infection, is something that we saw in our model as well, which is, I think, interesting. So having said that, these are all quite straightforward assays that look at a single virus at a time. And something that we are also working on, but 8 minutes is short, that I'm in particular also excited about is that we are also working on setting up a competition-based assay. So you can, for example, combine strains in a single well and look over time which strain prevails. So really characterize fitness in a competitive manner. Yeah. So I think we started with this, right? So for doing proper preclinical studies, we need an in vitro model that is biologically relevant, scalable, cost-effective, workable, and reproducible. And maybe we are not there yet, but I hope to have shown you that we are trying to work on this and that we are contributing to this goal. So I did tell you about how these novelly differentiated HNEC cells allow characterization of infection, different types of high throughput readouts that we are trying to optimize, including indirect ELISAs and imaging. And lastly, concerning future goals, we're quite excited to almost start working on a large screen in which we aim to compare 14 different strains that have different mutations with known or unknown consequence in nirsevimab binding regions, which is, I think, very relevant if you think about it. This is one of the most novel strategies, right, in the RSV field. And thinking about viral fitness and resistance, I think this will be interesting. So, having said that, I think this is one of the most important slides as well. So, Nefeli, our technician, did actually a lot of the work, and Hetty and Kimano were super helpful in setting up the submerged model itself. And we were super happy that Louis and Jonna took us along in starting up with RSV infections, because a year ago we didn't do a single thing ever yet with virus. So, thanks for that. And lastly, of course, AstraZeneca and Sanofi for all the discussions. So, thanks.
Thank you very much, Sasha. So I think we have time for 1 or 2 questions.
Sasha, great talk. Harrison Bergeron, University of Georgia. So I noticed when you're talking about the apical supernatant, you mentioned optimal media. are you allowed to clue us in on to what some of those ingredients are so that we can reproduce it?
Good question. I had to ask my PI before going here to check, and we are not, but the publication is going in the right direction. So we hope that in a couple...
It will get published?
Yes, for sure. Yeah,
right on.
Yeah, I mean, this is something we should all... If people want to use it, people should use it. So going in that direction.
I'll wait for the pub. Thanks.
Yeah.
Hi, great talk. Thank you so much. I was wondering if you did any comparisons between the viral replication kinetics between the submerged culture and the ALI-grown culture.
Yeah, we did initially indeed. And I think what we can say there is that, so we are still also optimizing the submerged model actually. And I have to be honest, and the ALI differentiation does result in, for example, more ciliated cells. And in that sense, we see that there's more infection as well in the ALI model than in the submerged model. But I think here you can play with your conditions. So for example, maybe an ALI model would allow you to see a nice S-shaped curve of infection 2 days post-infection, and we need 3. So the infection is less, but I don't think that's necessarily a bad thing. Yeah.
Do you, in your imaging, do you see any sort of like patterns of how the virus is spread? I guess I'm asking because with the ALI culture model, you can see virus spread through the mucus, which is going to be much more viscous than the supernatants.
Yeah.
And so I'm curious if the virus actually spreads a lot easier in something that it's easier for the ciliated cells to move.
Yeah, interesting. I think there it depends on the time points that you're doing. So here now, the imaging that you saw was 3 days post-infection, and there it's mostly single patches, so really a single cell. I can imagine if we would leave it for longer, then we would be able to characterize how the virus would spread and whether that would really be via the mucus, or I read some interesting things as well about connections between cells, let's say. So would be interesting, but not visible in how we set it up now. Yeah.
Great, thank you.
I'm really sorry. I think we have to move on, so maybe at the break. Thank you very much, Sasha. Our next talk is by Siripat Padasungal from Chulalongkorn University in Thailand. High seroprevalence of antibodies against human respiratory syncytial virus and evidence of RSV reinfection in young children in Thailand.
Okay, thank you so much, and thank you for giving me an opportunity to be here. I am Siripat Pasitangkut. I'm a PhD student from Chulalongkorn University in Thailand. Today I would like to present about the high seroprevalence of antibody against the human respiratory syncytial virus and evidence of RSV reinfection in young children in Thailand. Actually, as we know that RSV is the most common cause of lower respiratory tract infection in infants and young children worldwide, especially in children under 5 years, and it causes the greatest disease severity during the first years of life. And by the 3 years of age, almost all children will have been infected with RSV, and approximately 50% infected twice. Reinfection with RSV can occur throughout life and is usually symptomatic. Actually, when RSV infects the body, it can trigger the normal virus-specific antibody responses, include the humoral and cell-mediated immunity. Therefore, the presence of the anti-RSV specific immunoglobulin gene in the serum can indicate the RSV infection in the population. And I believe that the advantage of the seroepidemiological in the various geographic regions can provide a more better understanding of the RSV pattern in the community and inspire the more effective assessment of the role of antibody levels on infection and disease. Here, I would like to show you about the RSV incident in the young children in Thailand between 2016 and 2022. This data is from our laboratory in Thailand, and we confirmed the cases of RSV by using real-time PCR. And we observed that RSV was found in 16.9% and more prevalent in the rainy season in Thailand between July and November. And interestingly that no RSV cases were reported during the COVID-19 pandemic. Probably mostly due to most children were homebound, but after the relaxing of pandemic measure, we observe an increase in RSV cases. Therefore, our data is indicate that RSV is still more prevalent in Thailand since there is no licensed vaccination for RSV infection. It is very important to continue the research and monitoring of the RSV infection, especially in young children, for prevention and manage this infection. Therefore, our aim and objective is to better understand the characteristic of RSV infection and represent the pattern of antibody acquisition in the general population. Specifically, we investigated the seroprevalence of RSV infection in young children and to determine the correlation between RSV antibody levels and in maternal and cord blood, as well as providing evidence of RSV reinfection in Thai children after the primary infection. In the methodology, we collect the data and the serum sample from mother and children who participated in our long-term study of pertussis vaccination immunity between 2015 and 2021, and we obtained the ethical consent for use of this sample. And we use a commercial ELISA kit to evaluate the anti-RSV IgG antibody of these serum samples. And the test instruction included 16 and 22 relative units per milliliter as a cutoff point of seronegative and seropositive values. And the results of antibody RSV IgG antibody among the mother and children shows that more than 90% of children at birth were seropositive through the transplacental transfer of maternal antibody. Then maternal antibody gradually declined after 2 months, with the highest seronegative rate with seronegative rate at 7 months of age. However, antibody levels increased rapidly in their first infection at 1 year old and gradually increased with age, probably due to the nature of infection. However, more interestingly, there have many children aged 3 to 5 years had high levels of antibody exceeding 100 relative units per milliliter. And to given the more importance of maternally derived antibody in preventing newborn from infection, we aim to examine the correlation between the anti-RSV IgG antibody in maternal and cord blood. And there were 285 of mother and infants pair who were eligible for the research, and our analysis revealed a positively correlation between the mother and cord antibody concentration with a ratio of 1.09. This result suggests that maternal antibody are efficiently transferred to infant during the early childhood, providing protection against the RSV infection. And based on our finding, after 7 months of age, antibody titer tended to increase with a large number. With the large antibody levels existing 100 relative units per milliliter at children at age 3 to 5 years. And this is likely due to the children being reinfected with RSV. Therefore, we just examined the anti-RSV IgG antibody in the children with 150 children, and we found that there is some examples of children who had previously been infected with RSV and subsequently have a reinfection between 2 and 3 years. And another example is they just have a reinfection at 4 years after they got a primary infection after 3 years. In addition, we also found that young children in our study have a possibility of a true reinfection. And in the conclusion, more than 90% of Thai children at birth were seropositive through the transplacental transfer of the maternal RSV antibody. And our maternal RSV antibody in infants are rapidly waning after the 2 months, with the highest rate of seronegative rate at 7 months of age. And anti-RSV IgG levels increase with age as a result of natural infection, with the majority of seropositive was found in their first years of life. And the children are highly susceptible of RSV infection, may contribute to the ability of RSV to generate a repetitive illness. And from our data, we believe that children before age 7 months should be considered to provide adequate and safe RSV vaccination for prevention the RSV burden. And at the final, it would have been success without the help and support from my supervisor, Professor Yongpui Wawan, and my laboratory colleagues, as well as the grant provided by National Science and Technology Development Agency and Chulalongkorn University. Thank you.
Thank you very much. Jess, please.
Hi, Jess Atwell from Pfizer. Wonderful study. Thank you so much for sharing your data. I may have missed it, but my question is whether or not you collected the gestational age of the infants at birth, and if you have any insight into how the titers at birth or the ratios between mom and baby differed by whether they were full term or preterm when they were born.
Could you repeat the question, please?
Sure. Were all of the infants in the study full term at birth?
Yes.
They were, okay. Okay, great, thank you.
Thank you.
Great, and I have actually one question, which is, you had first infections and then you had reinfections, and it looked to me when I was looking at the graphs like the antibody titers were much higher after a second infection than after a first infection. Is that right?
Yes.
Yes. Okay. All right. Well, thank you very much. So our final presentation this session is from Ashley Weaver from Baylor University in the US on distinct basolateral infection phenotypes, differences between RSV subtypes.
Okay. All right. Thank you so much for the invitation. To have been invited to present as a graduate student is just a phenomenal opportunity. But as was said, my name is Ashley Weaver. I'm a graduate student at Baylor College of Medicine in Houston, Texas, in the lab of Dr. Pedro Piedra, the guy who's been asking a million questions today. But and today I'm honored to present my talk entitled Distinct Basolateral Infection Phenotypes, Differences Between RSV Subtypes. So as we've all heard multiple times today, RSV is the #1 cause of lower respiratory tract infections and hospitalization in children under 5 months old. However, despite knowing that information, it is still not 100% known what the mechanism is behind spread from the upper respiratory tract to the lower respiratory tract. So there are a couple of hypotheses, one being that RSV is aspirated to the lower respiratory tract when, during an upper respiratory tract infection, virus is secreted into the apical lumen along with sloughed off cells and pulled down to the more distal regions of the airways. But it's also been hypothesized that circulatory spread could potentially be a route of viral dissemination to other tissues such as the lower respiratory tract. There's been evidence showing that viral RNA has been detected in whole blood, immune cells in serum, as well as several extrapulmonary manifestations. So theorizing that it could be possible that RSV, if it's in a circulatory component such as blood vessels, lymphatic vessels, or infected immune cells, could potentially access the lower respiratory tract this way. So our lab hypothesized, okay, how could this actually happen? So say you have an upper respiratory tract infection with RSV. Damage occurs to the epithelium during infection, allowing the virus to escape where it could access the circulatory system and now have access to the basolateral epithelium of the lower respiratory tract and then start a whole secondary infection within the lower respiratory tract. So we've been referring to this potential mechanism of infection as the basolateral route of infection. So the question our lab wanted to address is, can RSV infect the airway epithelium via the basolateral route? So how we actually went about testing this, as Sasha so nicely laid out for me in her presentation, we also use a similar culture system to the primary cells, and that we've previously published a paper using human nasal organoids to study RSV pathogenesis. So having this model system already in place made it a nice, easy tool to be able to address if basolateral infection with RSV is possible. So we utilized two RSV strains, the RSV-A virus and RSV-B virus, the Ontario and the Buenos Aires strains, and we would, let's see, there we go. We would inoculate the basolateral compartment of transwalls of human nasal organoids at air-liquid interface, and we did this in 4 adult as well as 4 infant-derived lines to cover our bases and do this with both adults and infant-derived cell lines. We would let the infection progress for an hour and a half before removing the virus and replacing with fresh media. And then at subsequent time points, we would perform several apical media washes, or media washes on the apical side, and sample the media on the basolateral side. We would then use these samples to look at viral kinetics, and then we would also fix the cell layer to do immunofluorescent microscopy on at 8 days post-infection. So to get into the data that I have for you guys today, the first figure I'm going to be showing you is on some of the kinetics data we've generated in the adult lines first. So we have, there we go. We have RSV-A and RSV-B on the other side there, and this is looking at the amount of infectious virus that was detected on the apical side out to 8 days post-infection. So the first thing we noticed right away is that between RSV-A and RSV-B, there seemed to be a difference in the number of transwalls that we inoculated the basolateral side with that went on to become infected. So being a young graduate student and seeing this, I just assumed I messed up the experiment the first time. However, when we repeated this, the pattern actually held true, and that's for a second line that we repeated this infection with, we saw that only 1 out of 3 transwalls we inoculated the basolateral side with went on to become infected, while all of the ones with RSV-B went to become infected. So we do this a third time, slightly different results. This time we saw 3 out of 3 became infected for both RSV-A and RSV-B with basolateral infection. But the fourth line we repeated this with was very similar to the first 2, in that we saw only 1 for RSV-A, while all of them became infected with RSV-B. So ultimately, for the kinetics in the adult lines, we saw apical release of RSV-A occur in 50% of the transwalls that we inoculated, while 100% of the transwalls we inoculated with RSV-B became infected. So this was an interesting observation, because when we do apical infection in these HNOs with RSV-A and RSV-B, 1, we don't see a difference in infectivity between the lines. We see very similar nice replication curves occur between RSV-A and RSV-B. But we also see infection start to drastically increase by 2 days post-infection, versus in this model, we didn't even see apical release of the virus until 5 days, sometimes 5 days, sometimes 8 days post-infection. So this is a very different pattern of kinetics that we see with basolateral infection than what we see with apical infection. So we did the same thing with the infant lines. So in the figures I'm showing up here is looking at apically released RSV-A and B. Again, in the first infant line, we inoculated on the basolateral side. So in this line, we saw that RSV-A and RSV-B were able to infect all of the trans walls. However, this was the only line that we observed this with. As for every subsequent line we repeated this with, we did not see RSV-A show up on the apical side out to 8 days post-infection, where nearly all of the trans walls that we inoculated with RSV-B did become infected. So this mimicked very nicely what we saw with the adults as well. So overall, we saw apical detection of RSV-A occur in 25% of the wells and 83% of the time with RSV-B. Again, if we compare this to what apical infection kinetics look like, again, we see that the kinetics curves between A and B look almost identical, and that in the infant lines, by about 2 days post-infection, you have almost peak virus titer occurring, but in basolateral, again, it's not until 5 days or 8 days. So there's this drastic delay in when the virus is showing up on the apical side when we do basolateral infection compared to apical infection. So lastly, we performed some immunofluorescent microscopy on the trans walls that were fixed at 8 days post-inoculation. So we have some images here showing mock trans walls from adult and infant lines. And here, doesn't show up quite as great on the monitor, but we have a nice tightly knit epithelium, which is what we want to see in a healthy epithelium with beautiful cilia on top. However, when we performed immunofluorescent microscopy looking for RSV in wells that went on to become infected with RSV when it was put on the basolateral side, we see the damage that has occurred to the epithelium, but we also only saw RSV show up on the apical side, specifically the ciliated cells, which we know is the target cell for RSV. But given that we put the virus on the basolateral side, we were expecting to see RSV potentially be within the basal cell population, as we theorized that's what cell type would become infected first. But by 8 days, we only see it in the apical ciliated cells. This is very similar for RSV-B as well, and that by 8 days post-infection, we see RSV signals show up on the apical ciliated cells of the epithelium. So in summary, we believe there is a gap in knowledge that remains to be addressed in understanding if circulatory spread of RSV could contribute to the onset of lower respiratory tract infection. So the question we wanted to address was, can RSV infect the airway epithelium via the basolateral route? So we've had several observations thus far, firstly being that RSV-A is apically released from basolaterally inoculated HNOs around 5 days post-infection. Our second observation is that it seems that RSV-A and B differ in their ability to infect HNOs via the basolateral route. And lastly, by 8 days post-infection, the apical ciliated cells are infected with RSV. So all of these data points together have shown us this far that RSV can infect the epithelium via the basolateral route of infection, but of course there's much work to be done in this avenue. Specifically, we were planning to perform some flow cytometry experiments as we don't know what cell type is being infected early in infection, as we're only seeing it, RSV show up via immunofluorescent microscopy in the apical ciliated cells at 8 days. So if we do some flow cytometry experiments hoping to identify what cell types are infected throughout the course of basolateral infection. Secondly, we'd like to explore the differences in RSV entry receptor use on the basolateral side. As we know, RSV A and B primarily differ in their G or attachment protein, and we are interested in exploring, do RSV A and B and the differences in their attachment protein influence how they are using entry receptors on the basolateral side to establish an infection. And then lastly, we'd like to characterize the host response to this type of infection to see if it differs from what we call normal or apical infection. So I have so many people to thank, my lab, everyone back home, but specifically my mentors, Dr. Piedra, Dr. Vasanti Avadhanula. Our 3D organoid core at Baylor College of Medicine really makes a lot of this work possible, as well as our funding from the NIH. And of course, the Resvinet people for allowing young researchers to come and present their work to your audience. So at this point, thank you so much, and I would love to take questions. And find me at my poster.
So this is open for questions while we're maybe waiting. Oh, we're not waiting. Go ahead, please.
I was very fortuitously close to the microphone, and I don't know. Yeah.
If you yell, maybe I can hear you.
So in the context of looking at the road RSV may take in the airways, did you, and it's interesting, I'm sorry, Keena Swanson, Pfizer. So the observation that you saw between RSV-A and RSV-B, did you Are you thinking about also looking at within the context, you know, I'm thinking about dendritic cells and neutrophils that are sampling underneath, and if you infect different DC subsets of the neutrophils with an A strain or a B strain, and then put that progeny, or if there are progeny, onto a more permissive cell line or back into your model,
right.
What do you think you would see?
That would be possible. We actually have a whole other side project going on in the lab with incorporating immune cells into this. So if we were to mix or infect the, say, neutrophils and stick them back in, if the progeny is being released from those cells, I think I would expect to see something similar in that we've seen this pattern show up in both the adults and the infants. So I think if A or B has access to the basal outside the epithelium, that we would see that maybe difference in infectivity be maintained.
Hi there. Thank you. My name is Jonna from the Utrecht University. I had a question also about the more in vivo situation, because you've shown now that in vitro basolateral infection is possible.
Right.
And what you explained earlier, the theory, I guess, is that somewhere you're infected with RSV and it then enters the bloodstream. If that's from the nose going then to the lungs, is quite a long bloodstream.
Right.
Could you speculate about how RSV or any virus would survive such a long time in the bloodstream and how that relates to the viral load you use in your in vitro models?
Right. So it has been tough to find the literature that seems to be in all consensus about if it's possible, does it happen, and what are the incidences of secondary infection that could occur as a result of it. Then I think that, I'm sorry, could you repeat the last part of your question?
Yeah, so the last part of the question was how would leaking virus from a different part of the brain, part of the body, and then relate that to your in vitro situation?
Right. Short answer is I'm not 100% sure, but if you had a high enough viral load that potentially is in the bloodstream, maybe that increases the chances that some virus finds its way to the epithelium of the lower respiratory tract. As for the conditions, I would speculate that, virus doesn't last too long, and we know that RSV loses its infectivity pretty quickly, but it seems like there's a lot that's unknown in this field, and so this model system was like a very simplified way of kind of approaching at baseline, like, if the virus is there, could it be possible to infect? But now is where we get to do all the fun part of adding in the complexity, right?
Thank you.
Yes.
So I'd like to thank all four of our speakers. Please remember, please remember to vote. You can scan or go to this link, please, before Thursday evening. So one more round of applause for everybody, please.
Hi, everybody. We would like to go on with the last session of today.